system, wherein every mother through the RCH portal we used to ID. The RCH ID has been we create the ID and then thereby we track the mother where she goes for the antenatal checkup and where she delivers everything till it goes to the up to the immunization where the child gets all the immunization services.
Yeah, I think that is a new addition which has come in the RCH2 portal too, if I'm right recently.
Yes, sir.
Yeah. So now we'll move on to the, once the mother is there, the next part of the life, the child health. Dr. Basaraj, who is there with us, who is a community medicine man. Am I correct?
Yes, sir.
Yes, Mysore Medical College. Huh?
No, I'm from, I completed my undergraduation from Jain Medical College, sir. Post-graduation from KVJ Surya.
KVJ Surya, yeah. So that was a really good district to work actually. Now, sir, you know that always once the child is born, we always say the first day of life, first week of life, and the first month of life, and first year of life, the most important component. And most of the system strengthening, whatever we look at is related to the neonatal care. Usually we look at the system. So what do you want to share with us related to the latest things with respect to the neonatal and infant related health, sir?
Yeah. Thank you, sir. Now, confining myself to the discussion of SDG goals, now state has achieved the SDG goals much ahead, 8 years ahead of the target. But that is not sufficient. Now we are moving ahead to a single-digit mortality rates. When we talk about the child health aspect as such, there are many other components also in this, and I will confine my discussion to the medical care of it. If we see the descending limb of the mortality, whether it is under 5 mortality or the neonatal mortality, early neonatal mortality, in the last 2 decades, the initial slope was much steeper. And the last 5 years, the descent is not as fast as it was earlier. It is not 2-point reduction, 3-point reduction. It is even 1-point reduction is also difficult now. As we are approaching towards a single digit, the task is becoming much difficult. Now, if you see the last SRS also, now Karnataka data is showing 1-point increase in the infant mortality and 1-point increase in the under 5 mortality. We have sustained the neonatal mortality as 11 and early neonatal mortality as 7. Now, what that shows is that we have concentrated more on the neonatal part, which was very difficult and which has a higher component in all the under 5 mortalities. Now, to handle this, we have activities which can be segregated as community-based child care mortality, child care health services, and facility-based healthcare services. Under the facility-based, we have established multi-level care where we have ensured essential newborn care at all the delivery points. So wherever the mother gives a birth, so we have ensured that the baby will receive all the essential newborn care. And the second level is where we have established a stabilization units, what we call it as a newborn stabilization units, where the critical babies are stabilized and given a pre-referral treatment, and during referral treatment also is provided till it reaches to the higher level. And the next level is a special newborn care units. Now in the last 5 years, we have doubled the number of units in the state. So we have made sure that at least every district will have 2 special newborn care units, well equipped, and the minimum number we have maintained it as 12. So now these specialized newborn care units are at par with the corporate setup, even in the government setup also. And along with the huge network of these hospitals, we are even utilizing the private setups also through the ABRK, which was discussed sometime back in the other panel discussion. So now, more importantly here, sometime back we equipped all these special newborn care units only with the non-invasive ventilatory support units. But now we have moved ahead, and all our special newborn care units are now supported with even the invasive ventilatory support units, machines. So the level 3, level 4 kind of a special newborn care units are also are established in the state. Now this is one part on the facility-based care, and on the community-based care now we have two programs. One is the HBNC, that is home-based neonatal care, wherein field workers and more importantly ASHAs will give a structured visits to the home itself, and they examine the newborns and identify the early danger signs and refer if it is if they find any danger sign in the newborn. So after this first 42 days, the child is also followed up to 1.5 years with the HBYC, that is home-based young child care. Now we are just modulating these two community-based programs to one program, and we are stratifying the children, and this will be a completely a digital platform where every child is moving around. And I heard some time back from the audience that now digitalization is making it more complicated, and I find that digitalization is making more, it is easing the monitoring part and even helping the service providers also. Now once a child is entered anywhere, it need not be entered in this platform itself. If the child is entered in the Poshan tracker, if the child is entered in the immunization platform, if the child is entered at the birth registration itself to avail the birth certificate, the name will flow into this digital platform. So every field worker will be knowing how many children she has in her area who are less than 30 to 28 days, and what is the child condition, and what is the status of this child in terms of the immunization or the nutrition status, everything. So the children will be stratified, and more focus will be given those children who need more care. So this was one challenging area for us till now. As long as the child was there in a safe hand in the hospital under the pediatrician care, we were happy. But when the child is at the point of a discharge, that is actually more worrying part. Because after that, who will take care of this vulnerable child? That was a more important thing. So now we have even digitalized the community-based part also, and we have many other thoughts also which are still in the piloting phase. So that is how now we have evolved, and we have understood the challenge that now further reduction is a little more difficult, and we are prepared to that part, and we have many more things that are under the piloting phases.
Thank you, Dr. Basuraj. I think that was a lot of the changes are happening, and what we sometimes talk about theory are already happening in the state of Karnataka and in the country. And as you mentioned, we know that when the morbidity and mortality is high, the efforts required when it comes down is double or triple the efforts when it comes to single digit and more. The high risk definitions also change actually. That's what we are seeing, that the definition of high risk or the issues to be tackled will be much more difficult when the figures come down to lower level, and further reducing is even more challenging. That's what we're looking at.
Exactly. Now if you see, Kerala has shown 5-point increase in the infant mortality. Doesn't mean that the care has come down. Now actually, like even in Karnataka also, if we analyze, the neonatal mortality has remained stagnant and the infant mortality has raised. Now earlier those children who were actually supposed to succumb in less than 7 days or less than 28 days, now we are giving them the enough care, and they're passing that 28 days. So statistically they are falling into the infant mortality rate. So increase in the infant mortality is, this kind of a trend is quite natural, and one point increase is not that it's a reverse trend. It is in fact showing that all those children who were into the neonatal mortality rate now are coming into the infant mortality rate. So 1 point increasing basically for epidemiologists now, with considering all these factors, shows that now the neonatal care has been improved in Karnataka.
Also, I think denominator also now changes, probably certain calculations, the effect of those things also.
Yes.
I think now we will move on to the next thing. Dr. Anil. Dr. Anil, in fact, is a physician. I have seen him. He was senior specialist in Averi District Hospital, if I'm right. That point of time, he moved on to TB cell way back in 2008, 2006, 10. When I was in WHO, I have seen him, how he came to STDC, first State TB Training and Demonstration Center, And that point of time, we had DOT strategy. And then in 2006, we had the Stop TB strategy. Now we are having, with the MD, SDG and all those things, we have NCB strategy. And we had NTB strategy goals themselves are there. Then SDG goals are also there. With related to TB also we have. And now India has got we want to achieve much earlier than where Prime Minister himself has announced these things. Now in technology, if you see, I think if I remember Epicenter, the software which we are using in 2000 itself, when we had just 1G, 2G speed, there is nothing called data in mobile. So that time itself, though with the 2G speed itself, we were happy that that point of time, within 1 month of quarter is over, we were able to publish, country able to publish the data, which many developed countries were not able to do. In fact, we used to listen, even America was not able to do at that point of time. But today, there are a lot of changes. What has happened, not happened in last 50 years, probably happened in last 15, 20 years in the field of tuberculosis like many other areas. And now to achieve this, definitely these technologies and new technologies as well as the equipments and tools which are important for us. In last 10 years, if you want to put us, what are the new things which has come into the system in the NTEP now? Starting from, of course, RNTCP has become NTEP. That itself was a paradigm shift in the program which has happened. Sir, over to you.
Thank you. This is a very loaded question. In the diagnostics, we moved away from microscopy to NAT. So the microscopy would require at least 10,000 live bacilli for somebody to be declared, for 1 ml of sputum to be declared as TB. Now with ultra, even if he is having 10 to 15 colony-forming units, we can diagnose somebody on TB. So that is the first change that we brought about. And all these days we were looking at standardized treatment. Now our focus is on DST guided treatment. We have the all oral longer regimen which focuses on DST guided treatment. The most important thing that has happened, if you ask me, in the diagnostics, these are the two things. In the treatment, we have now injection-free treatment. If somebody would have seen the treatment of drug-resistant TB, the MDR TB and XDR TB, the treatment duration was 24 to 27 months, 6 to 12 months of intramuscular injections of aminoglycosides. Today we have reduced it to 6 months of BPAL regimen. So just now I was reviewing the Kolar districts. We have put 6 patients on BPAL for pre-XDR. All the 6 are cured. So when I started my journey in TB, the success rates for MDR TB was 48%. The success rates for XDR TB was just 33%. Today, we have a success rate of 80% for MDR TB. So next is the universal drug susceptibility testing. So this is a game changer. Probably if there are any clinicians here or people here, TB is the only disease where DST is offered to every microbiologically confirmed TB. You have, we emphasize on microbiological confirmation. NAT gives rifampicin resistance, the first line LPA, second line LPA, liquid culture. Finally, a drugogram is given to the patient and then treatment is given. That is again a very big change. Of course, you know, from intermittent regimen, we moved to the daily regimen based on the weight bands. From the past 2 years, the most important change that has occurred, the most fascinating thing that I have seen is the TB preventive therapy. You know that Karnataka had the highest HIV TB prevalence, 17%, and the 3B districts had something around 40%. The epidemiology of HIV has not changed. In fact, the numbers of HIV patients have gone up. But then HIV TB is reduced to 5% in the state. The only one change that we did was TB preventive therapy. So every patient, after ruling out active TB, we have started giving TPT. And TPT protects to the tune of 90%. So the breakthrough infection, after putting 82 1,000 HIV patients, we have just hardly 28 people. So it's a very good protection rate. And you were speaking on technology. We are using AI. We have used 30 plus vulnerabilities mapped up to the level of villages. That's one thing. We have now got AI in imaging, chest x-rays. So that is another thing that we are doing. The third thing that we are using is the chatbot. Stigma towards TB is there. There will be so many questions that the patient or their caregiver wants to ask that they'll be not able to ask. We give them a chatbot with 3,500 questions, most common questions. The patient can listen to it, confidentiality is maintained, he can delete the questions. Now we are planning to have cough sounds for TB. Just as for heart you have an ECG, you have a cough sound for lung diseases. It can tell whether a patient is or a person is having obstructive or restrictive lung diseases. And the most newer thing that we are now looking at is avatars for patient care. So you ask, there will be something popping up and telling him the right things. These are the things that are going on. And the incident TB in Karnataka is down by 40%. But then we have the Kalyana Karnataka with highest incident TB. So that is the focus area for us. The mortality rates have reduced by 50%. Our success rates have risen to 90%. So these are some of the achievements in the last 10 years that we've seen.
I think listening to you, we say the medical college textbooks are the most outdated books on the earth today related to tuberculosis. What we are learning in the medical colleges, what we are teaching is far behind actually what we are looking at that. So that's one of the important things. So unlearning what we have learned to learn the latest things is also one of the requirement, I'm sure. So with digital adoption, what we are looking at TB being among the communicable, one of the leading leading diseases still goes ahead. Now the technology adoption now coming to the technology man, who was, we can say, he has done, Dr. Arun, as Arun Kumar did it, e-health. Also, you can see a lot of the e-Sanjeevani was there, Telemanas, e-hospital softwares, and so many awards also. Karnataka, I'm sure you will start with the awards and the achievements of Karnataka first, before going to the details. So ABDM is one of the, even medical colleges. Organ transplant, yeah, he was also officer for organ transplant, so there are a lot of laurels when Arun was leading all these things. Today he has moved to the State Institute of Health and Family Welfare. And ABDM now, you know that recently there was a circular from NMC also, all medical colleges also should adopt ABA IDs for their patients in the medical college. There was a circular. Sir, Dr. Arun Kumar sir, would you like to throw us what are the latest things adopted in technology in Karnataka, especially? In Karnataka there are some pilots and then taken to the national level also, if I'm right.
Yes.
Please, over to you, sir.
So thank you. I thank the institution for giving me this opportunity and also the organizers. So in Karnataka, we are initiated lot of digital initiatives, especially this can be directly or indirectly can be related to the SDG goals also. We started the telemedicine in 2002, though it was located in few places. Now it is universal. From 2019, it is universal. We have implemented in all districts. Even the general public also can utilize the teleconsultations. In teleconsultations, around 18,000 teleconsultations are happening per day in Karnataka. We are using our own officers for this. So this indirectly it will reduce the amount, the labor, especially in the rural area. He has to travel time is reduced. His daily wages for 1 day or 2 days is reduced, and the attender, he has to take the attender. All these things have improved, especially in Karnataka. Our own medical officers who are here, they know they are also giving the teleconsultations. And we have initiating the tele-radiology and tele-ICU. Very short. Tele-ICU we have already implemented in 53 Taluka hospitals. See, Dr. Baswaraj was talking about the SNCU, PICU, Pediatric Intensive Care. So what happens, we have the ICUs, especially in the Taluk hospital and district hospitals, SNCU. Whenever they want any suggestions from the intensivist, they can contact. We have 4 hub centers in the Bangalore Medical College, Mysore Medical College, Hubli, and Kalburgi. So their intensivist will support our doctors, especially pediatrician may not be available 24/7 in the Taluk hospitals. So these intensivists are helping, especially in the 43 hospitals. Now we are extending to the all the SNCUs, all the PICUs, and also other MMU surgical units. So that is in our pipeline, and very shortly we have already MOU with the provider, the platform provider. This is saving, for example, perinatal mortality is reduced by 20% if you give proper care in the SNCU. Similarly, especially the trauma patients, road traffic accidents, and mortality rate, especially even these are taken care in our own ICUs, and this it is helping also. In the teleradiology, that's also we are initiating that one. The challenge is tenders, while 2 tenders have been cancelled. Now 3rd tender has been initiated. There we want to implement all modalities, 7 modalities we are implementing, not only the radiology aspect, only X-ray. We are want to implement this for our MRI, CT scan, tele-ECG, tele-ophthalmology, tele-echocardiography, tele-Doppler. All these 7 modalities, and this is the first of its kind in the entire India. We have not seen, we have seen only teleradiology, but for the all the modalities, we want to include, expand the further. But this is the thing, and we have identified. We incentivize our own radiologist for giving the reports for this especially. But for the platform, we are going for the tender. That is the thing, challenge. Only the tender is the challenge for us. Next, Madam was telling, especially the perinatal, during the perinatal period, we are using the ARC photography. ARC photography is the, from past 1.5 years, we are using more than 40,000 deliveries. See, photography was invented 50 years back by the WHO. But the photograph was filled retrospectively in the institutions. And now it is the real time. If you go and see in Kolar itself, in any Taluk hospital, if you go and see, staff nurses will explain how to enter the in the real time photography in the digital. They are very happy. And this is, they are identifying the high-risk mothers at the initial stage only. This is also the reason for the reduction in the mortality rate. Especially when you go here about 2 years back, there was lot of news about the pregnant women deaths. So in Karnataka, during that period, all these things, all these changes. Here we are using the technology. So, and you might have also heard about the STEMI program. STEMI program, where in the Taluk hospitals, especially in the non-communicable disease, where the patient come with the chest pain. The Taluk hospitals have this program, and they will take a X-ray. Digitally, it will be transferred within few seconds. Within 5 minutes, the reports will come. And if the patient is identified as any elevation of the ST segment, immediately the drug is also available and drug is given. This has prevented lot of premature mortality, which is one of the SDG goal. So this technology, we have adopted a lot of technology. Not only this thing, we have telemanaged. Especially those who are in distress can contact daily telemanaged. Initially, the call will go to the counselors. If counselor find it has to be referred to a specialist, then immediately it will be referred to the specialist in the demands. So telemanaged. So like this, we have, the government have initiated multiple initiation of the digital technology. But technology cannot replace the doctors. And that is the important thing. But the technology can amplify the doctors. So government cannot provide specialists to the all the corners of the state. You know that around 20%, in Karnataka we have around 25% of the specialist shortage, 20% of the MBBS shortage. So in such cases, how to we have using these technologies to reach the thing. In previous panels, we were discussing about the equality and universal healthcare. How to reach? Only the technology can give the solution for this. With these remarks, I close my.
Thank you, Dr. Arun Kumar. I think that is a wonderful technology. We cannot say, though addiction is one side, we are telling technology, we have to live with that. And present generation at least has not, don't know the other side of the world. There was no such technology existed when we were the children or whatever it is. Now last section, just 1 minute, few minutes. Now that you were also DRP nodal officer from government side, Commissioner of Health and Family, for all of
Yes.
you come to add. We are posting postgraduates across the state to the taluk hospitals and district hospitals and the general hospitals, and community medicine people are going to the program officers, health commissioner office. So what are the benefits they can get? If you can add just 1 minute, if anybody else also want to add. Can
Yes,
also.
yes. So I am the state nodal officer for DRP from the health and family welfare side. So we have around 76 medical colleges where we get around 66 colleges have post-graduation year. Around 5,300 postgraduates are there, and in any quarter 1,200 to 1,300 DRP students will be there. Bangalore have more, around 26 colleges where our maximum DRP students are posted in the local area. Initially, as per the NMC guidelines, we were posting the students into the same district, so that they will be in the control of the DHO. Wherever there is gap in the infrastructure, human resource, there we had given permission according to our guidelines. And there is another thought in the government. So we want to utilize all the DRP. This year there is a mismatch. Actually, in few areas there are DNB students are there in our hospitals, and even DRP students will come. And for example, if I give in KCG medical, KCG General Hospital, there are around 20 OBG DRP students will be there at any given point of time. There will be no place to sit also. That is another challenge. We have already seen these things. Now, I have developed an application in-house, similar to our counseling, what we are doing. We have developed a digital application to post, to monitor the DRP students. Based on this is my plan. It is not yet executed, and it is in the stage of execution. So based on the need ranking, we will do the counseling. The hospitals, the medical colleges will list out all the DRP students in their college. They will only enter the list in the, they can upload the complete sheet into that application. So no need to send in the email. So it will automatically, their application will be there. Principal will verify and it approve. After approval only, it will come to our state center. Then the medical college only will give allot the students according to the quarter 1, 2, 3, 4. So based on the NEET ranking, we want to do the counseling. So all over Karnataka, for example, there are 600 students in anesthesia postgraduates are there. That is the maximum number of anesthesia PGs are there. These 600 can be posted in around, when I divide, 150 taluk hospitals. So this 600 will be posted to all taluk hospitals. So quarterly one will replace the other, and the same taluk hospital. Now they are concentrated in few districts only, wherever the medical. For example, if I go to Yadgiri, there are no medical colleges. Still the medical college do not have the post graduation. There are no thing. Now we can, that is the intention. And regarding accommodation and the TADA, what the NMC tells, for that, so we want to, they have stipend. Additionally, we may provide some amount for their accommodation, and the one-time DA will be given. DA will be given for the 3 months, and the TA will be given for the one time only, while coming for the DRP postings and going back to the parent institution. This is the idea.
Looks interesting. Let us see how it works.
I don't know how it will get. I have proposed, and the government has to take decision.
Because there are challenges this side and that side. At
There are
PGs
challenges
also,
are there.
government colleges, private colleges, payment, and so many kind of things, issues also. Let us see.
We will take suggestions before implementing. We will be having a meeting with all the medical colleges. We will also take the inputs, and then only we will finalize.
So thank you, Dr. Harun. I think there are a lot more to ask actually to discuss, but then in the interest of the time, I am sure they are already looking at us. We are closing here. I don't think there is time for question session also. Oh, Dr. Anumantaya sir. Anumantaya sir was my teacher in Hubli, KMC Hubli, and he was a professor HOD of dermatology at KMC Hubli, and then he was at Vaidehi Institute of Medical Sciences, professor HOD at dermatology, and he came to Kolar. Now he is professor emeritus in Devarajars Medical College. Sir, mic please. Somebody give the mic. Ah.
One single dose of rifampicin for all the household people. Will it not cause in near future resistance to rifampicin for tuberculosis patient?
Sir, your first question was
Vitamin D,
vitamin D in TB.
treatment of tuberculosis regimens.
Yes, sir. There are, many papers that are published saying that vitamin D deficiency would become a nidus for future TB. But in our country, when we look at vitamin D levels, every alternate person is having low vitamin D. Having said so, if there are some non-responders to treatment, or if somebody is coming with TB for the second time and the third time, we look at vitamin D levels. We also look at the therapeutic drug monitoring levels. So based on these two, and some immunomodulators are added to the patient. That is how we treat TB patients. And second thing is single dose rifampicin. Sir, for mycobacterium to develop resistance, these single dose, single exposures will not lead to drug resistance. Usually what happens is a resistance is subtherapeutic doses of a particular drug given for a pretty long period of time, or from the patient side, he takes medicine for 3 days, drops the medication for 1 week, takes for 3-4 weeks, again drops the med. This intermittent regimen will augment the resistance. And the third thing, what we do is, we usually insist on everybody who's putting on prophylaxis to rule out active TB and then put the TB preventive therapy.
Thank you, sir.
Thank you so much.
Yeah, you are. Introduce, sir.
Good evening, sir. This question to Dr. Anil once again. We appreciate and applaud ourselves and claim that the development advances in the diagnosis and the treatment has brought about a tremendous change in the success rate of treatment in XDR, MDR, TB. This is across the country. And when we talk upon zonal level of discussions, South Zone has done a tremendous job and the medical colleges have contributed immensely for the success of tuberculosis in the goals, whatever. When we have done all these things, as you mentioned yourself, Kalyana Karnataka region is not able to replicate. So what is that uniqueness or the hindrances or the obstacles to replicate the same success in the other regions of Karnataka, in the Kalyana Karnataka region? What difficulties we are facing? Is it from the etiological agent point of view, or the other factors, cofactors, or the participation of the people in the implementation of the program?
All the four things put together.
Yes.
So
Thank you.
I think before that, I think I have attended many, at least state level meetings, review meetings, last 20-25 years back. We used to always hear in Vikas Saudha, Vidhan Saudha, Health Minister, Health Secretary telling always priority for 6 C districts and Chamarajnagar. Am I correct? That used to be, I think that was part of lot of the Kalyan Karnataka. I'm sure with all the systems, what we have, maternal, child health, TB, NCD, even technology adoption, everywhere these challenges are there. I think that was a wonderful question. You want to add to that?
Sir, in terms of a child health services, it is not as bad as it is projected. Like we say, as if it is to the level of, or rather 2 decades back or whatever it is. Even the recent SRS statistics also showed that. Now the good part is SRS is showing its mortality rate in terms of 4 divisions of the state: coastal division and northern inland, southern inland, and eastern inland. All. Now, if you see the under 5 mortality or even the neonatal mortality also of all these regions, this Chikmagalur eastern coastal eastern inland, that is Chamarajnagar and Kodagu and all this, have higher infant mortality rate compared to even the Kalyan Karnataka rates. And I don't know, now we have to little get the detailed into all these things. But it is not as bad as it. So now if you see the average of, if you see when we say infant mortality as 15 for the whole state, it is just 17 for the Kalyan Karnataka region, 2 points high. But the reduction rate, if you see, like now we don't have the divisional level statistics for the earlier SRS, but in days to come we can see that. Now more importantly here, we are now just getting into the family participatory care of a child health services. I'll confine myself only to the child health services. Now it is very difficult to involve the whole family into the care of a child in these regions. Now we all know the obvious reason for that. And more importantly, the kind of the profile of the patients that we get into the medical services for the child health care, those families are completely different. Even see, there is a difference between urban and rural, and even in the rural also there is a difference in the Kalyan Karnataka regions. But one thing is there, that it is not as bad as we all are thinking. In terms of the recent statistics, we know that there is much is being done there. But the challenges are completely different there. We have to have different kind of strategies to address those things. That is the reason now when it comes to the child mortality, we are now designing, earlier 2 years back we thought of having a Karnataka Newborn Action Plan, KNAP. But we know now, like when all this started, we were just reviving from the shock of a COVID. So we couldn't take it up to that level, what we expected. But now, over the period, we realized that now that will not work. One specific strategy for the Karnataka will not work. So now we are further drilling it down to a DNAP, District Newborn Action Plan. So wherein the district will sit and design their own action plan. So we are not now going to the state level action plans. We are now drilling it down to the district action plan. And as such, a state is also, not just our department, state is now concentrating at the block levels, in fact. There are some blocks even on the other side of the Karnataka also, which are vulnerable for many regions, for many factors. So now we are just drilling it down, the strategies to the district level, and we are concentrating the blocks in that. So definitely those regions will be at par with the other part of the Karnataka. But challenges are completely different. It is not that strategies, we have to have different strategies for those regions.
There is a neglect on the part of the government, and they want a separate state so that they can improve. I don't want this to be the reason for them to separate.
That is a political question, I think.
That becomes a political statement. But the statistics will not support that statement, and they have a different board itself, and much emphasis has been given on that, not because of it is neglected. The challenges are different, has to be addressed differently. Now state is working on that.
Thank you. I think with this we will stop the panel discussion. I thank the panelists, Dr. Indra Kabadi, Dr. Basuraj Dabadi, Dr. Anil, Dr. Arun Kumar for your wonderful insights into the government perspective towards the achieving the Sustainable Development Goals, specifically Sustainable Development Goal 3 and beyond. Thank you very much. I thank the organizers for our opportunity.
Thank you, Dr. Ravindra sir, for this and team for this engaging and interactive panel session. Now I invite Ravindra sir to felicitate all the speakers. Dr. Anil Kumar sir. Dr. Basavraji Dabadi. Dr. Arun sir. Dr. Indira Kabadi ma'am. Now I invite Dr. Dayanand sir and Dr. Prasanna Kamath sir to felicitate Dr. Ravindra Reddy sir. Thank you, dignitaries. Now, general body meeting will be starting shortly. We come.
We come to the last scientific session of today. Gender equity, equality in healthcare, bridging policy and practice and lived reality, SDG Goal 5 and SDG Goal 3. I request the moderator, Dr. Ramesh Masti sir, Professor, Head of the Department, Kempegoda Institute of Medical Sciences and Research Center, Bangalore, to grace the dais. And I request the speakers, Rashmi Kundapura ma'am, Dr. Deepthi ma'am, and Dr. Samudita ma'am, to grace the dais.
Good evening to one and all. We'll be now starting the last session, and I'll introduce our panelists for today. We'll be starting with Dr. Rashmi Kundapur, who needs no introduction. She is currently working as an additional professor at AIIMS Delhi, AIIMS Bibi Nagar, Hyderabad, and she is well known in the field of community medicine. She is also one of the main authors for the IAPSM textbook of community medicine, and also many other research textbooks that we have come out with. and she has also worked a lot with relation to gender. And I would now call upon Dr. Rashmi Madam to start.
Okay, good evening. We'll try to finish it as early as possible. So the topic was gender equity in healthcare, from patients to the professionals, or like old SDG 5. So I'll be focusing on building institutions where every gender receives equitable and dignified care. So we are talking about this, why it matters. The case for gender across the healthcare touchpoints is very, very essential. Patients, providers, institutions, all are more important for us. Policies, training, and structural reforms that drive the real progress and real-world cases we look into. I would want to say that we have all the perspective we look into. It's not just male, female. We also have the third gender, which is facing the issues what we are saying. Men face stigma around seeking care for especially mental health, and there is underreporting of the disease, and there are specific blind spots in the research of mental health because men are supposed to be more strong. They cannot sustain to have issues on mental health. So as a mental health perspectives, men by themselves are differentiated. Female are disproportionately underdiagnosed, undertreated, and underrepresented in many of the clinical trials. I am by myself running the trials, and when we look into the trials, of course, purposefully or non-purposefully, we try to underreport because of many things like pregnancy, do not want to take issues of pregnancy, or if she has some issues of menopause, we do not want to deal with all that. So in many of the trials, most of the trials, in all the vaccine trials, drug trials, most of the trials, women are disproportionately not taken into consideration, but the same drugs are given to the women, but they are disproportionately part of the trials. This is just an example I'm giving. Third gender, all of you all know, the intersex, non-binary, transgender, gender diverse individuals face systematic exclusion from standard care frameworks. We do not have the rainbow acceptance all over because many of them perceive that gender is a fluidity, but we are not yet expecting that to accept the fact of gender fluidity, which is among the majority of the people. So gender equity means equal access, quality, and dignity. That is very, very important. Dignity in all that, and not identical treatment, but tailored for the individual, what we are talking about. So now the number tells the clear story. If you look into, I'm talking about the third gender individuals face the steepest barriers in most of the healthcare, which may be avoiding the care altogether due to the fear of discrimination, misgendering, and outright refusal of service. Sometimes it does happen. Women 50% more likely to be misdiagnosed on post-heart attack. Trans individuals four times more likely to forego needed care. And women in healthcare leadership globally are only 25% of the global leadership is among the world healthcare leadership is only in 25%. Whereas 50% of the whole gender it is, but only 25% of them are there. So you have 25% leadership role only, and there is a misdiagnosis which occurs. So the gender influence which symptoms diagnosis, usually women are supposed to put up on anxiety, more of the treatment. If you can go in the field and see also, the many of the treatment are put on anxiety rather than the real reasons. It is not taken quite seriously. Many of them are treated for gastritis. Many of them are treated for stress, thought of stress, when there could be something else which is not. And non-binary patients are also looked into like that. Drug dosages, surgical protocols, and pain management are majorly looked. When we want to take any of the trials on surgical procedures, male body is taken into as a clinical standard when we look into. So the care quality report, lower trust, worst outcomes. Recently I wanted to just put up, was meeting some gynecologists, and suddenly the gynecologist said that whatever said and done, the male gynecologists are supposed to be still the best gynecologist. So Why is that perspective? Are the males really better or the females are better? It is a perspective that because a surgeon, males could be a better surgeon compared to a female. This was the concept taken. So that is why by the patient perspective and also from the healthcare perspective. So that is the reason most of the things, they still continue to say that male gynecologists are supposed to be still better than the female gynecologist, though many of them do not want to enter. So that's the perspective of the gender care you can look into. So 50% it is caused that leading cause of death, heart disease is a leading cause of death in women, where 50% are likely to be misdiagnosed following the heart attack as compared to men. Among the men, if you have their misdiagnosis, 50% in this are more men. So nausea, jaw pain, shortness of differ as classical chest clenching image. Unless they get some other smaller symptoms, they are not diagnosed. Women wait an average of 11 minutes longer in emergency rooms for cardiac evaluation compared to men. This is a world perspective. I'm not talking about only Indian. So they have 11 minutes longer to wait in emergency as compared to that. So third gender, systematic exclusion you have, misgendering, being announced in a different pronoun, not giving the psychological effect they have, refusal of care, and research gaps. Any of our research do not include, means any trials or any of the drug trials, vaccine trials does not have an inclusion of third gender within them. So they are completely excluded from the part of our, where they are also part of it. So we have seen that the case study, Hijra recognition and health policy, the implementation gap among them remains a larger one where you can look into. So gender bias among healthcare professional, 18% gender pay gap is there. Average earnings between male and female is physicians globally. 18% gender gap between the males and females globally. This is whole part difference in male. 25%, I told already, the CEO and senior leadership roles are only led by females. 75% is by males. 70% of the female nursing force are females, but yet the promotions and earnings of male nurses are better than the females. 2 times more burnout. Physicians report burnout of twice as compared to that of male colleagues. That's always been seen that burnout is more common among so the workload becomes. So breaking the glass ceiling is, how do we do it? Mentorship networks, programs pairing junior femme and non-binary clinician with senior leaders for the career advancement or equity mandates, visibility and advocacy could be so non-binary and transgender professionals publicly leading departments signal that the medicine is a field for every gender, which is not happening. But we have certain non-binary and transgenders now coming out as MBBS graduates at least. I think they should be included into the part of it, or that trans who continues to be included on. But it's quite difficult happening even in the institutes, national institutes. Again, the talk becomes very, very touchy for people when we talk about transgenders and inclusion of them, or when we talk about them. Still the people of various forensics think that it could not be that they will be able to give back as supposed to be as males. So that's the inclusion. Institutional policies should be started on pronoun. At least we should start training the staff on proper use of pronoun. What is the pronoun? LinkedIn, I think, properly gives. You define what it is. He, she, or she, or it is for now he or she. So something we should be very clear that what we should be using. Inclusion forms offering male and describe their options, what they want to, and neutral spaces. Gender neutral bathrooms are very much essential, and this is the major chunk what at least hospitals should start using it. Gender neutral washrooms, changing rooms, and ward allocations, so that the transgenders and others could be also taken into consideration. So the need here is training for equity, sensitivity training, clinical practice should be in such time, curriculum should be reformed. How many of our curriculums include that gender equity as a part of it? It has never been part of even the I do not know how many of our undergraduates are confident to come up and say that they are among the trans or they want to turn up into the trans, because it's not been taken into consideration. There is a continuous. So Canada has introduced X-gender marker in federal health records, allowing non-binary individuals be accurately identified and receive treatment. New Zealand has developed inclusive care framework, mandating gender-affirming language, third gender data collection, and cultural safety. Argentina has passed one of the world's progressive gender identity laws, granting individuals that the right to self-identify without medical gatekeeping, where you have to go, males have to go here, and females have to go here. So gender equity cannot be through single policy. It requires systematic, sustained commitment across 6 interconnected pillars, from boardroom to bedside. So we should put up that policy to explicitly third gender identities, collect that, build feedback loops with patient communities and leadership advantage. So the key takeaway is gender equity is a patient safety. Misdiagnosis, exclusion, and bias cause measurable harm across all genders, especially for third gender. Global models show that it's possible. Change must be structural, not superficial, just not sexual, but it should be present structural. Every institution can start today, and that's the part of it. Okay, thank you.
Thank you, Dr. Rashmi. I would now call upon Dr. Deepthi. She's working as a professor at ASI Medical College, Bangalore, and the floor is yours. Dr. Deepthi has been working in the field of disability, and she's been also a big proponent of gender equity. And she's, I think, was working in SDUMC for a good many years before she joined ASI Medical College. To save time, by the time the PPTs are on, I would ask is gender, to Dr. Rashmi, is gender equity a patient-centric issue, or is it a human rights issue? What is your opinion on that?
Okay. I basically believe that both the issues are included in this. It's an patient safety issue, because of which the patients, any of the genders, it's not just male and female. I think male and female could be easily taken as not as a patient safety, because we have, but when it comes into the third gender and the transgender or binary, then it becomes a patient safety. And when it comes into the only two genders, when we talk about a lot of human rights issues comes into picture. But both the issues are human. It's a basic right of an individual to have a good quality healthcare. So it's also a human right issue, but also in the healthcare, it's a patient safety issue we should consider into.
Okay, I think, yeah, thank you.
She's over here. I'll be talking about leaving no women behind. Understanding vulnerability, building resilience in achieving the Sustainable Development Goals. We know women are vulnerable group, but how do we decide this vulnerability? One is they have unequal exposure, which is mixed with the sensitivity, and there is lack of adaptive capacity. These are the things which will determine a person's vulnerability. We know that women are vulnerable, but even among those women, there are so many who are more vulnerable. Like whether they are from some particular geographic area, whether they're facing violence, whether they have a disability, whether they are poor, what is their age, are they children or elderly, and this vulnerability will increase more when these things are intermingled. Like if she is a poor, rural, disabled woman, then her chances of being highly vulnerable is a lot. Now, how do you identify the major vulnerable groups in India? Based on the life cycle and biological things, definitely are adolescent girls, pregnant and lactating women, and elderly women. When we speak about the socioeconomic margins, women who are poor, the tribal and rural women, then migrant and informal workers. And coming to systemic and health crisis, women with disabilities, single or widowed women, women experiencing violence, and women living with HIV. So these are the various major vulnerable groups among women. And to back whatever I said, if you look at the NFHS 5 findings, if you just look at the anemia crisis in what it shares is that almost half of adolescents are having anemia. And more than half of women between 15 to 49 are having anemia, and almost every other pregnant women are having anemia. And if you look at the decision making, it's actually a paradox. It says that 89% of the currently married women are taking decisions in the family, according to the survey. But at the same time, you see that 29% of women are facing spousal violence. And it is hard, it was even shocking to see that there are so many women who are girls who are getting married before 18, and it is almost 23.3%. Now coming to the topic of my interest, that is women with disability. The equity is even more increased. India has 26.8 million, which is very less, though census says, because now again census has removed estimating disabilities. And women account for 11.8 million. That is 44% of the women of disabled belongs to women. And why they are, if you look at that, they don't have any education, they will not be employed, then their access of maternal health care is low, and they don't receive any preventive screening, and they don't participate in any household decision making. And also, when they surveyed, they found out that they experience more violence, and they are the people who live in poverty, and they have unmet healthcare needs. Now coming to the professional women. We all may think professional women means they are empowered. How come they are vulnerable? Yes, they are the emerging vulnerable group. So this is called a leaky pipeline. So if you look at that, we have a double burden. One side, we are encouraging women to get educated, to go to job, but at the home and our environment and community is not prepared to tackle or to support empowered women. So she has to face a dual burden where she has to work and come back and also take care of the burden which happens at home. So 41% of the women participate in unpaid caregiving as compared to the men, which is 21.4%. And this leads to, as Dr. Rashmi said, a lot of workplace burnout, greater work-family conflict, and emotional exhaustion. Then we have seen a lot of hostile environment, especially. There are rules, but still 70% experience workplace harassment. And 60% experience sexist hostility, 44% unwanted sexual attention, and 40% gender-based bias. Next, coming to the motherhood penalty, which is considered as the utmost wonderful thing, but 75% face career setbacks, 1 to 2 years for sure, but many of us even leave the profession. And 48% of the people, of the women who joined back, quit their work within 4 months. Then if you look at the ceiling, that is, if you take at the high level, there is a difference in the wage between a man and a woman. And if you look at the leadership, 20% of corporate management roles only are women, and only 8 to 12% hold the CEO position. I just want to bring to the notice that even in Catch, until now, we don't have a female president or or secretary till now. Yes, when I speak of gender equity, it's not just linked to 5, SDG 5, but it is also linked to other things. When all the other things are taken care of, 1, 3, 4, 8, 10, 16 are taken care, then only we can move towards the gender equity of SDG number 5. So how do we build this resilience? First, we need to recognize. When I say we need to recognize, it's not just the women. yes, women have to recognize, and also all others have to recognize that yes, there is a systematic gap which needs to be fulfilled. Then it has to be revealed. So there need to be studies, there need to be surveys which will exhibit or expose whatever it is happening, and then we all have to sit together and resolve this. Then only we can achieve. A nation's success cannot be determined by how a strong woman has achieved. It should be determined how the poorest vulnerable women have come out of it and achieved something in a community. Thank you so much.
Yeah. Thank you, Deepti. I would now like to call upon Dr. Samyu Datta. She is working as an associate professor at Devarajars Medical College, and she is the young budding phase of Catch. We welcome you for your talk. Yeah, I will now ask Dr. Deepti to save time. Are women inherently vulnerable, or society creates vulnerability?
Sir, I don't believe women is inherently vulnerable. I completely agree it is a society created vulnerability. Because if a woman is given proper education, she gets proper guidance and support, she can reach as much height. Like even a pregnant woman, if she gets the proper care, we won't end up in maternal death. Maternal death happens in the areas where it is socially created vulnerability is present. So I completely believe that women is not inherently vulnerable. It is a society created, and it can definitely be changed.
Thank you. Yes, madam.
Thank you, sir. Good evening, respected all. So I'll be talking about how Gender 5 is related to the other Sustainable Development Goals, and how achieving SDG within each of the other Sustainable Development Goals is important to accelerate the development overall. And I'll also be talking about certain strategies that we can adopt to achieve this. So I want the audience to look at the picture on the left. So we see an old woman, quite healthy looking, not that old also. You can disregard the color of the sari, that is AI generated, of course. I didn't say bright sari, dull sari, okay. But she looks a bit worried, maybe because of knee pain, I don't know, maybe, okay, maybe knee pain, and maybe because of years of unpaid work that she has done, and knee pain, which she considers to be normal for her age. Okay, and she's sitting there quietly, and she is being attended by all servants. So she is from an affluent family. So who do you think decides who cooks in that or what is cooked in that family? Maybe she decides the menu. She decides what menu has to be prepared. But who decides what is the quality of the food that has to be fetched? Who decides what to shop? Who decides where to go for healthcare? Who decides what medicines she should take, or which brand of medicines she should take? How much should be her healthcare expenditure? We don't know. Maybe it is not her. Okay, so there is an invisible barrier even in affluent families where all the facilities are available, but women, especially women of old age, might be still suffering from some kind of inequality. And it may not be only women, it can be men also, if they are not financially independent. So women who are not financially independent or are not digitally literate still do face some kind of inequality throughout. And on the left, you see that ambition gap, like ma'am was earlier mentioning. So she's looking at a watch, and there's a child crying. I wonder why she's not calling for help. So the society sees this, and they think, why is she alone in that house? Is there nobody to take care of the child? Can't she afford a servant, or does she not trust the servant? Or is there no family member who can come and take? Is she a single mom? Okay. And what made her a single mom? That is more interesting than finding out why she has to be worried about taking care of the child, while she could actually be doing both if she had some support. So who is failing all these people? So the system is failing all these people, women, men, or even third gender. People, people might have a lot of capabilities, but the system somehow and somewhere is failing them. So that is what we are going to talk, and I strongly believe that the achievement of goals in other sustainable developments would eventually lead to the achieving gender equality as well. So look at no poverty, the SDG 1 no poverty. If the current trends persist, we will be actually pushing 351 million women into poverty. They are already there in poverty. We will not be helping them to come out. So we do have governments, we do have policy making bodies which are giving interim solutions, which are giving short-term solutions. So we have, this is the time where we have to shift from short-term solutions and go for empowering them so that it is more sustainable. So if we continue at this pace, we will be actually meeting all our goals only by 2125, that is 2125, maybe. And we also have this situation where if we achieve the sustainable goals by the deadlines, then we will be actually reducing the poverty by 128 million. And ma'am was talking about anemia. So there is a rising anemia globally. This is global stats. So 42 million more women and girls can become food secure if we actually achieve the sustainable development goals like we want to. And economic growth can also be accelerated. So women basically are facing this situation because they are dedicating a lot of hours to unpaid labor, okay, throughout their life, and sometimes ungrateful labor also, and are getting paid less for that. So, and this cycle continues, and somewhere they are at a disadvantage because of the societal norms. Similarly, look at the second goals also, zero hunger. So here, women do, both men and women face food shortage, but women disproportionately face the lack of nutrients as well. Consumption of nutritional foods is less among women. Again, maybe because of traditional or societal norms. So this goes along in all the other goals also. So we were talking about the global health workforce. About 67% of the global health workforce is women. But when it comes to leadership, there is a systematic exclusion, and there is almost a 24% pay gap. In education, we see that there are higher number of women teachers or female teachers, and we also have studies which show that women-led organizations have added to the learning. But when it comes to actually the leadership positions, women are less even in education. And SDG 6 water is a primary concern because the primary custodians of water are usually women, but we do not have inclusive policies which concentrate on women. So this goes along for SDGs 7, 8, and even 10, where women-led organizations are not given priority. And we actually do not measure several important things, like what is the percentage of women, or what is the gender breakup, or gender disaggregated data for official development of assistance, essential service spending, or even pro-poor public spending. How much of this goes to women? How much of this goes to third gender? We do not have this disaggregated data at a global level through SDGs at least. So some of the countries like India, we have started working on certain indicators which are gender specific, but not all. Even zero hunger at a global level, at SDG indicator frameworks do not measure the prevalence of undernourishment, food insecurity, stunting, or malnutrition on gender basis. So they do not collect information or collect data on this basis. Same thing goes for NCDs, comorbidities, risk factors like tobacco use, alcohol, mortality from pollution, deaths due to road traffic accidents. These are all not measured through the indicators of SDGs. So out of all these 240 indicators of the SDGs, only about 54 are measuring it gender specific. So you can see that some of these do not even have gender-specific disaggregated data. So at the national level, we do have some data for this gender-specific indicators, but not at the global level again. So we have this Beijing 30+ action agenda as well, so which concentrates on 6 points. So the first is digital revolution, so bridging the digital gender gap to unlock economic and social access is important. And now with the advent of AI, we must also understand that many of the jobs that can be lost due to AI would be basically women. So because women are in positions like clerical positions or accounting and such things which can be quickly replaced by AI, use of AI. So again, that is a huge risk. Second thing is like what they were talking about, like not including women in trials or studies. So this creates something called as AI algorithmic bias. So this algorithmic bias is this new kind of bias which has suddenly appeared in our research, where the AI is, they develop the data based on, or their database from the data collected from men predominantly, and thus creates a bias towards the other gender. So freedom from poverty, again, not giving them financial assistance, but also giving them or empowering them to achieve the no poverty status is also important. Zero violence, again, all organizations, all households, all policymakers should keep this in mind whenever they are devising any new policy. So zero violence policies should be a part of all new policies that come up. And the women should be included in decision making. So we have, in fact, in India, we are seeing a paradigm shift where we are shifting from women empowerment to women-led empowerment. And yeah, yes, sir. And finally, in climate justice, again, we are all facing this climatic issues, and women are at higher risk because of their, again, societal norms. And this is somewhere where women-led organizations should be focused on. So I think I have covered most of the points that I wanted to talk about. So thank you so much for the opportunity. I also thank Dr. Rashmi ma'am and Dr. Deepti ma'am for including me in their panel discussion, and Ramesh sir for moderating. Thank you so much.
Yeah, thank you. So we are way beyond the time for the day's activity. Just one question. So what is the, in keeping gender, what is the role of healthcare policymakers in attainment of SDG 5?
So healthcare policymakers, again, should keep gender in mind when they are devising the programs, policies, and indicators. So any indicator that we are making, we should check whether we have gender disaggregated data, and whether any gender is being left out when we are measuring the impact and measuring the process. So all those evaluation indicators must be carefully reviewed and implemented.
Okay, thank you. So over to the organizers.
Thank you, panelists, for this wonderful, insightful session on gender equity and equality in healthcare. I now request our moderator, Dr. Ramesh Masti, sir, to hand over the mementos to Rashmi ma'am, Deepti ma'am, and Samudita ma'am. I request Dr. Prasanna sir and Dr. Sunil sir to hand over the mementos to the moderator, Ramesh Masti sir. Thank you, panelists. This will be followed by the general body meeting in the same hall. Kindly stay back in the same hall. So with this, we come to the end of today's scientific session. On behalf of the organizing committee of Catch Conference 2026, I extend our heartfelt gratitude to all the esteemed speakers, chairpersons, delegates, and participants for your valuable contributions and enthusiastic participation throughout the day. We believe that today's deliberations have been informative, inspiring, and professionally enriching. Following the general body meeting, we invite you to join us for the cultural gala program at SK Inn Resort, followed by dinner. Thank you and have a wonderful evening.
To please join for the general body meeting. I request Dr. Girish sir, Dr. Girish, President Catch, Dr. Ravinder Reddy sir, Vice President, please rise. Dr. Girish B, Treasurer. I request President, Vice President, and Treasurer. ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಕರ್ನಾಟಕ ಅಸೋಸಿಯೇಷನ್ ಆಫ್ ಕಮ್ಯುನಿಟಿ ಹೆಲ್ತ್ annual general body meeting ಗೆ I welcome one and all for all the distinguished members. With permission of chair, the agenda for this annual general body meeting is as follows. Welcome and calling the attention of general body meeting with permission of president and other obituary reference and action taken on the previous general body meeting at Catch Conference, Jims Kalburgi, and report by treasurer and the next conference and any other matters with permission of chair. So these are the agendas for the general body meeting. I request president to give permission and to first obituary reference. I request all the members obituary reference. Earlier our Catch, one of the senior member, founder, Dr. P.V. Ashwath sir, Madam Dr. Sheila was a professor, HOD in the Bangalore Medical College, and if I am right, Mr. M.S. Rao sir from the Ramya Medical College. I request all the members to join for a moment. Start for the 1 minute silence. Thank you. ಅಸೋಸಿಯೇಷನ್ ಪರವಾಗಿ ಐ ರಿಕ್ವೆಸ್ಟ್ ಐ ಪ್ರೇ ಗಾಡ್ ಫಾರ್ ದ ಆತ್ಮಕ್ಕೆ ಶಾಂತಿ ಸಿಗಲಿ ಅಂತ. ಸೊ ನೆಕ್ಸ್ಟ್ ವಿಲ್ ಮೂವ್ ಆನ್ ಟು ದ ನೆಕ್ಸ್ಟ್ ಅಜೆಂಡಾ. ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಕೊಬೋದು. Action taken on the previous general body meeting. The previous general body meeting was on the last conference in the Kalburgi gyms ಆಗಿದ್ದು. ಲಾಸ್ಟ್ ಕಲಬುರಗಿನಲ್ಲಿ ಡಿಸ್ಕಷನ್ ಮಾಡಿದಾಗ ಜನರಲ್ ಬಾಡಿನಲ್ಲಿ ಕೆಲವಷ್ಟು ಪಾಯಿಂಟ್ಸ್ ಹೈಲೈಟ್ ಆಗಿತ್ತು. ಒಂದು ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡಬೇಕಾದ್ರೆ ಪ್ರತಿ ಕಾನ್ಫರೆನ್ಸಲ್ಲೂ ಕೂಡ ಸೈಂಟಿಫಿಕ್ ಕಮಿಟಿ ಅಂತ ಒಂದು ಮಾಡಬೇಕು, ಸೊ ದಟ್ ಅವ್ರದ್ದು ಒಂದು ಅಡ್ವೈಸ್ ತೊಗೊಂಡು ಸೆಷನ್ಗಳನ್ನೆಲ್ಲ ಪ್ಲ್ಯಾನ್ ಮಾಡಿ ಅಂತ ಹೇಳ್ಕೊಂಡಿದ್ರು. ಸೊ ಹಾಗಾಗಿ ಬಾಲು ಮತ್ತು ಅವ್ರ ಟೀಮು ಮತ್ತು ಕೆಲವರೆಲ್ಲರೂ ಸಜೆಸ್ಟ್ ಮಾಡೋದು, ಸೊ ದಟ್ ಇಟ್ ಈಸ್ ಎ ಪಾಲಿಸಿ, ಅಂದರೆ ಒಂದು ಸಿಸ್ಟಮೆಟಿಕ್ಕಾಗಿ ಹೋಗಲಿ ಅಂತ ಅದ್ರ ಬಗ್ಗೆ ಒಂದು ಸ್ವಲ್ಪ ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ. ಅದನ್ನು ಕೂಡ ನಮ್ಮ ಸ್ಟಾರ್ಟಿಂಗಲ್ಲೇ ಕೂಡ ನಮ್ಮ ಸುನಿಲ್ ಸರ್ ಮತ್ತು ದಯಾನಂದ್ ಸರ್ ಅವ್ರಿಗೂ ಕೂಡ ಕನ್ವೆ ಮಾಡಿದ್ವಿ, ಟೀಮ್ ಏನಾದ್ರು ಮಾಡಿ ಇದು ಮಾಡ್ಕೋಬೇಕು ಅಂತ. ಏನಾದ್ರು ಹೇಳ್ತೀರಾ ಸರ್? ಅದು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ, ಸೊ ಹಾಗಾಗಿ ವಿ ಆರ್ ಆಗ್ತಾ ಇದೆ ಸರ್. ಎರಡನೇದು ಲಾಸ್ಟ್ ಟೈಮು ಬಿಕಾಸ್ ಆಫ್ ಸಮ್ ಟೆಕ್ನಿಕಲ್ ಇಶ್ಯೂಸಿಂದ ಅವಾರ್ಡ್ಸ್, ಕ್ಯಾಚ್ ಅವಾರ್ಡ್ಸ್ ಏನೇನಿತ್ತು ಎಲ್ಲದು ಕೊಡಬೇಕಾಗಿತ್ತು.
This is the issues which came up in the previous general body. There has been some action taken. I request the secretary to tell that action taken. If there is any comments on that action taken, we can take it up after he completes the report.
ಸೊ ಅವಾರ್ಡು ಲಾಸ್ಟ್ ಟೈಮ್ ಒಂದೆರಡು ಅವಾರ್ಡ್ ಕೊಟ್ಟಿರಲಿಲ್ಲ ಬಿಕಾಸ್ ಕೆಲವೊಂದು ಕಾರಣಾಂತರದಿಂದ, ಸೊ ದಟ್ಗೆ ಆ ರೆಕ್ಟಿಫಿಕೇಷನ್ ಆಗಿದೆ. ಸೊ ದಟ್ ಈ ಸಲ ಇರ್ತಕ್ಕಂಥ ನಮ್ಮದು 12 ಅವಾರ್ಡ್ಸ್, ಅಂದರೆ ಬೆಸ್ಟ್ ಕಮ್ಯುನಿಟಿ ಪ್ರೊಫೆಷನಲ್ ಅವಾರ್ಡು, NGO ಅವಾರ್ಡು, ಲಿಟ್ರರಿ ಅವಾರ್ಡು, ಹಾಗೆ ಈವನ್ ಈ ಸಲ ಬೆಸ್ಟ್ ಥೀಸಿಸ್ ಅವಾರ್ಡು ಕೂಡ ಕೊಟ್ಟಿದೆ, ಪ್ಲಸ್ ಕಮ್ಯುನಿಟಿ ಚಾಂಪಿಯನ್ ಅಂತ ಏನು ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡಿದೆ. ಎಲ್ಲ ಅವಾರ್ಡನ್ನು ಕೂಡ ಕೊಡಬೇಕು ಅಂತ ಲಾಸ್ಟ್ ಟೈಮೇ ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ದೆ. ಸೊ ಹಾಗಾಗಿ ಕಮಿಟಿ ಮೆಂಬರ್ಸ್ ಡಿಸೈಡ್ ಮಾಡಿ ವಿತ್ ಪರ್ಮಿಷನ್ ಆಫ್ EC ಇಟ್ ಹಸ್ ಟೇಕನ್. ಸೊ ಆಲ್ ದಿ ಅವಾರ್ಡ್ಸ್ ಆ್ಯಸ್ ಪರ್ ದಿ ಕ್ಯಾಚ್ ಬೈಲಾಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಥ್ಯಾಂಕ್ ಯು. ಡಾಕ್ಟರ್ ಬಾಲೂರು ಲಾಸ್ಟ್ ಟೈಮು ಏನೋ ಕೇಳಿದ್ರು, ಅವಾರ್ಡ್ ಶುಡ್ ಬಿ ಗಿವನ್ ಟು ಆಲ್ ದ ಸರ್ಟಿಫಿಕೇಟ್ ಥ್ರೂ ಕ್ಯಾಚ್ ಅಂತ. ಐ ಅಗ್ರಿ. ಲಾಸ್ಟ್ ಟೈಮು ನಾವು ಬೇರೆ ಕಾರಣಗಳಿಂದ, ಸೊ ಅಸೋಸಿಯೇಷನಿಂದ ಮೆಂಬರ್ಸ್ ಮಾಡಿಸಿಲ್ಲ. ಈಗ ಅಜಯ್ ಸರು ಲಾಸ್ಟ್ ಟೈಮ್ ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡಿದಾಗ ಅವ್ರದ್ದೇ ಇದರಲ್ಲಿ ಕೊಟ್ಟಿದ್ರು. ಸೊ ಹಾಗಾಗಿ ಬೇಡ, ಅಸೋಸಿಯೇಷನ್ ಕಾನ್ಫರೆನ್ಸ್ ಆಗಿರೋದ್ರಿಂದ ಕ್ಯಾಚ್ ಅವ್ರದ್ದು ಇರೋವಂಥದ್ದು ಮೆಲಿನಿಯಂ ಅವಾರ್ಡ್ ಇರ್ಬೋದು ಅದನ್ನಂತ. ಸೊ ಹಾಗಾಗಿ ಅದನ್ನ ಈ ಸಲ ನಾವು ಮಾಡ್ಕೊಂಡಿದ್ದೀವಿ. ಡಾಕ್ಟರ್ ಗಿರೀಶ್ ಅವರು ನಿನ್ನೆ ಸರ್ಟಿಫಿಕೇಟ್ಸ್ ಒಂದು 20 ಸರ್ಟಿಫಿಕೇಟ್ಸ್ ಮಾಡ್ಕೊಂಡ್ಬಂದಿದ್ದಾರೆ. ಯಾರ್ಯಾರು ಬೆಸ್ಟ್ ಮೆಲಿನಿಯಂ ಪೇಪರ್ಸು ಎಲ್ರಿಗೂ ಕೂಡ ಕೊಡೋದಕ್ಕೆ ರೆಡಿ ಮಾಡಿಸಿದೆ, ಕರೆಕ್ಷನ್ ಆಗಿದೆ. ಲಾಸ್ಟ್ ಟೈಮು ಡಾಕ್ಟರ್ ಹೇಮಗಿರಿ ಆ್ಯಂಡ್ ಟೀಮ್ ಅವರು ಸಜೆಸ್ಟ್ ಮಾಡಿದ್ರು, ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡ್ತೀರಾ, ಕಾನ್ಫರೆನ್ಸ್ ಬರೀ ಅಕಾಡೆಮಿಕೇ ಆಗ್ತಿದೆ, ಸ್ವಲ್ಪ ಎಂಟರ್ಟೈನ್ಮೆಂಟ್ ಇರಲಿ, ಕ್ವಿಜ್ ಆಗಲಿ ಮತ್ತು ಕ್ಯಾಚ್ ಕಪ್ ಅಂತ ಏನೋ ಅಡ್ವೈಸ್ ಮಾಡಿದರು, ಸಜೆಸ್ಟ್ ಮಾಡಿದ್ರು. ಈ ಸಲ ಅದ್ರ ಬದಲು ಒಂದು ಸ್ವಲ್ಪ ಏನು ಎಂಟರ್ಟೈನ್ಮೆಂಟಿಗೆ ನಿನ್ನೆ ಸಾಯಂಕಾಲ ಏನೋ ಒಂದು ಈವೆಂಟ್ ಆಗಿದೆ. ಸುನೀಲ್ ಸರ್ ಅಲ್ಲಿ ನಾಟ್ ಜಸ್ಟ್ ಅಕಾಡೆಮಿಕ್ಸ್, ಸೊ ಎಂಟರ್ಟೈನ್ಮೆಂಟು ಇರಲಿ, ಅಂದರೆ ಒಂದು ಯಾವುದಾರ ಒಂದು. ಸೊ ಹಾಗಾಗಿ ಸ್ಪೋರ್ಟ್ಸ್ ಇರ್ಬೋದು ಮತ್ತಂತ. ಸೊ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಿದ್ದೆ ನೆಕ್ಸ್ಟ್ ಟೈಮ್ ಮಾಡಬೇಕಾದ್ರೆ, ಬಿಕಾಸ್ ಒಂದು ಕ್ರಿಕೆಟ್. ಎಸ್ ಮುದುಕರಿಗೆಲ್ಲ ಏನೋ ಮಾಡ್ರಪ್ಪ ಹಂಗಾರೆ ಹೇಳ್ತಾ ಇದ್ದಾರೆ. ಆಯ್ತು, ರೈಟ್. ಓಕೆ, ಹಾಂ ಆಯ್ತು. ಹಿಂದ್ಗಡೆ ಏನೋ ಹೇಳ್ತಾ ಇದ್ದಾರೆ ಮೆಂಬರು. ಆಯಿತು ಸರ್, ಆಯ್ತು. ಓಕೆ, ಆಯಿತು ಸರ್. ನೋ ಒಂದು ಸಜೆಷನ್ ಬಂದಿದ್ದು, ಡೆಫಿನೆಟ್ಲಿ ಇಟ್ಸ್ ಎ ಗುಡ್ ಐಡಿಯಾ. ಸೊ ಹಾಗಾಗಿ ವಿಲ್ ಡಿಸ್ಕಸ್ ವಿತ್ ಇದು ಇಂಪ್ರೂವ್ ಮಾಡ್ಕೊಳ್ತೀವಿ. ಲಾಸ್ಟ್ ಟೈಮು ಕ್ಯಾಚ್ ಜರ್ನಲ್ ಬಗ್ಗೆ ಒಂದ್ಸಲ ಹೇಳಿದ್ರು, ತುಂಬ ದಿವಸದಿಂದ ಡಿಸ್ಕಷನ್ ಆಗ್ತಾನೆ ಇದೆ. ಕಾನ್ಫರೆನ್ಸ್ ಆಗ್ತಾಯಿದೆ, ಪೇಪರ್ಸ್ ಎಲ್ಲ ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತಾರೆ, ವೈ ಟು ವೇಸ್ಟ್, ಸೊ ದಟ್ ಒಂದು ಜರ್ನಲ್ ಥರ ಮಾಡ್ಬೋದು ಅಂತ. ಸೊ ಅದಕ್ಕೆ ಈ ಸಲ ಸುನೀಲ್ ಆ್ಯಂಡ್ ದಯಾನಂದ ಟೀಮ್ ಅವ್ರು ಏನು ಮಾಡಿದ್ರು, ಒಂದು ಕ್ಯಾಚ್ ಜರ್ನಲ್ಲೇ ಮಾಡಿಬಿಟ್ಟಿದ್ದಾರೆ, ಸ್ಪೆಷಲ್ ಇಶ್ಯೂ. ಸರ್ ಬೆಳಿಗ್ಗೆ ನಮ್ಮ ನಮ್ಮ ಚೀಫ್ ಗೆಸ್ಟ್ ಅವರು
We have our own journal, our institution journal, JCBS. So we had taken consent from all the delegates who had submitted their abstracts. So 60 people had given consent for publishing those abstracts in our JCBS journal. So that was released today, sir.
ಗುಡ್ ಸರ್, ಥ್ಯಾಂಕ್ ಯು. ಸೊ ಅಟ್ಲೀಸ್ಟ್ ಅಸೋಸಿಯೇಷನಿಂದ ಆಗಬೇಕು ಅಥವಾ ಒಂದು ಇದರಿಂದ ವಾಟ್ ಎವರ್ ದ ಇಟ್ಸ್ ಎ ರಿಸರ್ಚ್ ಇಟ್ ಶುಡ್ ಬಿ ಶೇರ್ಡ್ ವಿತ್ ದ ಕಮ್ಯುನಿಟಿ. ಅದಕ್ಕೆ ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ, ಡೆಫಿನೆಟ್ಲಿ ವಿಲ್ ಕನ್ಸಿಡರ್. ಲಾಸ್ಟ್ ಟೈಮ್ ಕೂಡ ಹೇಳಿದ್ರು ಕ್ಯಾಚ್ ವಿಸಿಬಿಲಿಟಿ ಮತ್ತು ಆಕ್ಟಿವ್ ಆಗಿ ಮಾಡೋದಕ್ಕೆ ಸಸ್ಟೈನ್ ಆಗೋದಕ್ಕೆ ಡಿವಿಷನ್ ವೈಸ್ ಮಾಡಬೇಕು ಅಂತ ಅರವಿಂದ್ ಮತ್ತು ಅವ್ರ ಟೀಮ್ ಅವರೆಲ್ಲ ಸಜೆಸ್ಟ್ ಮಾಡಿದರು. ಡಿವಿಷನ್ ವೈಸ್ ಆಗಬೇಕು ಅಂತ. ಅದು ಕೆಲವೊಂದು ಕಾರಣಗಳಿಂದ ಇನ್ನೂ ಡಿಫರೆನ್ಸ್ ಆಫ್ ಒಪಿನಿಯನ್ ಇದೆ ಅಥವಾ ಸೆಂಟ್ರಲ್ ಟೀಮ್ ಅವ್ರು ಬಿಟ್ಕೊಡ್ತಾ ಇಲ್ವೋ ಗೊತ್ತಿಲ್ಲ. ಸೊ ಹಾಗಾಗಿ ಅದು ಒಂದಿದೆ, ಇಶ್ಯೂ ಏನೂ ಆಗಿಲ್ಲ. ಮೇಡಮ್ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಆ್ಯಂಡ್ ಟೀಮ್ ಅವ್ರು ಹೇಳಿದ್ರು ಕ್ಯಾಚ್ ವೆಬ್ಸೈಟು ಅಪ್ಡೇಟ್ ಆಗಬೇಕು, ಆಗಿಲ್ಲ ಇನ್ನೂ ಅದೇ ಅಂತ. ಅದು ಕರೆಕ್ಷನ್ ಆಗಿದೆ. ಸೊ ಇವಾಗ ಮೆಂಬರ್ಸ್ ಜೊತೆ ಕೂಡ ಡಿಸ್ಕಷನ್ ಮಾಡಿದ್ದೀವಿ. ಇವಾಗ ಇರೋ ಎಕ್ಸಿಸ್ಟಿಂಗ್ ಕ್ಯಾಚ್ದು ಇನ್ನೂ ಸ್ವಲ್ಪ ಡೈನಮಿಕ್ ಆಗಿ ಕೇಳಿದಾಗ ಎಕ್ಸ್ಪೆನ್ಸಿವ್ ಜಾಸ್ತಿನೇ ಆಗ್ತದೆ, ಬಟ್ ಆದರೂ ಪರವಾಗಿಲ್ಲ ಅಂತ ನಮ್ಮ ಅಧ್ಯಕ್ಷರು ಹೇಳಿದ್ರು. ಸೊ ಹಾಗಾಗಿ ಇವಾಗ ಯಾರೇ ಮೆಂಬರ್ ಆಗಿದ ತಕ್ಷಣ ಬೈ ಡಿಫಾಲ್ಟ್ ಆಟೋಮೆಟಿಕಲಿ ಅವರಿಗೆ ಮೇಲ್ ಹೋಗಬೇಕು ವಿತ್ ನಾನು ಮೆಂಬರ್ ಆಗಿದ್ದೀನಿ ಸರ್ಟಿಫಿಕೇಟ್ ಬರಬೇಕು, ಅಥವಾ ನಂದು ಸೊ ಅದು ಕೂಡ ಆಗಿದೆ ಸರ್. ಅದು ಕೆಲವಷ್ಟು ಪ್ರೋಸೆಸ್ಸಲ್ಲಿದೆ. ಪರಬಲಿ ಎಲ್ಲ ಡಿಸ್ಕಸ್ ಮಾಡಿದೆ ಇ ಸಿ ಮೆಂಬರ್ ಜೊತೆ, ಮತ್ತು ಅಧ್ಯಕ್ಷರು ಕೂಡ ಅವ್ರಿಗೆ ವೆಬ್ಸೈಟ್ ಡಿಸೈನ್ ಅವ್ರಿಗೆ ಏನೇನು ಬೇಕು ನನಗೆ ಅಂತೆಲ್ಲ ಹೇಳ್ಕೊಟ್ಟಿದ್ದಾರೆ. ಈಗ ಬೇರೆ IAPSMದು ಬೇರೆ ಅಸೋಸಿಯೇಷನ್ಗಳದ್ದು ಏನಿದೆ ಅದನ್ನೆಲ್ಲ ತೋರಿಸಿ ನಮ್ಗೆ ಈ ಥರ ಬೇಕು ಆಕ್ಟಿವೇಟ್ ಮಾಡಿಕೊಡಿ ಅಂತ. ಸೊ ಹಾಗಾಗಿ ಅದನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ಶಾರ್ಟ್ಲಿ ಆಗ್ತಾಯಿದೆ. ಅದನ್ನು ಅಧ್ಯಕ್ಷರು ಡೀಟೇಲಾಗಿ ಹೇಳ್ತಾರೆ. ಲಾಸ್ಟ್ ಅದೇ ಅದಕ್ಕೆ ವೆಬ್ಸೈಟ್ ಬಗ್ಗೆನೇ ಇನ್ನೊಂದು ಯಾವುದೋ ಬೇರೆ ಇದು ತೊಗೊಳ್ತೀನಿ ಅಂತ ಗಿರೀಶು ಲಾಸ್ಟ್ ಟೈಮ್ ಹೇಳಿದ್ರು. ಬಟ್ ಯಾವುದು ಕಡಿಮೆ ಅಂದರೆ ವರ್ಕೌಟ್ ಆಗ್ತದೆ ವಿತ್ ಕಾಸ್ಟ್ ಎಫೆಕ್ಟಿವ್, ಅದು ನೋಡ್ಕೊಂಡು ಮಾಡೋಣ ಅಂತ ಸಜೆಷನ್ ಬಂತು. ವೆಬ್ಸೈಟ್ ಅಪ್ಡೇಷನ್ ಅದಾಯಿತು. ಮೇಡಮ್ ಸುಧಾಶ್ರೀ ಕೂಡ ಲಾಸ್ಟ್ ಟೈಮ್ ಸಜೆಸ್ಟ್ ಮಾಡಿದ್ರು, ಶಿ ಬ್ರಿಡ್ಜಿಂಗ್ ದಿ ಗ್ಯಾಪ್ ಬಿಟ್ವೀನ್ ದ ಓಲ್ಡ್ ಆ್ಯಂಡ್ ನ್ಯೂ ಮೆಂಬರ್ಸ್ ಆ್ಯಂಡ್ ಆಲ್ಸೋ ಕೆಲವರು ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಇರೋರು ಇಲ್ಲದೇ ಇರೋರು ಎಲ್ಲರನ್ನೂ ಸೇರಿಸ್ಕೊಂಡು ತೊಗೊಂಡೋಗ್ಬೇಕು ಅಂತ. ಸೊ ಹಾಗಾಗಿ ಈ ಸಲ ಕಾನ್ಫರೆನ್ಸಲ್ಲಿ ಅವ್ರಿಗೂ ಕೂಡ ಪ್ರಿಫರೆನ್ಸ್ ಕೊಡಬೇಕು. ಸೊ ದಟ್ ಒಂದು ಪ್ಯಾನಲ್ ಡಿಸ್ಕಷನು ಮತ್ತೊಂದು ಮಾಡಿ, ಸೊ ದಟ್ ಬಿಕಾಸ್ ಅವರ ಅನುಭವನೂ ಕೂಡ ಕ್ಯಾಚ್ ಮೆಂಬರ್ಸ್ ಯಂಗ್ ಬಡ್ಡಿಂಗ್ ಡಾಕ್ಟರ್ಸ್ಗೆ ಅನುಕೂಲ ಆಗಂಗೆ. ಐ ಥಿಂಕ್ ಡಾಕ್ಟರ್ ಸುನೀಲ್ ಆ್ಯಂಡ್ ಟೀಮ್ ಅವರು 2-3 ಈ ಸಲ ನಾವು ನೋಡ್ಬೋದು ಶೆಡ್ಯೂಲಲ್ಲಿ 2-3 ಪ್ಯಾನಲ್ ಡಿಸ್ಕಷನ್ ಅವ್ರದ್ದೇ ಇಟ್ಟಿದ್ದಾರೆ. ಸೊ ದಟ್ ಎಲ್ಲರೂ ನಾಟ್ ಓನ್ಲಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಬಿಯಾಂಡ್ ಅದು ಕೂಡ ನಮ್ಮ PGಸ್ಗೆ ಸಿಗಬೇಕಂತ. ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ PGಸು ಬಂದವರೆಲ್ಲ ಹೊರಗಡೆನೇ ಇದ್ದಾರೆ, ಒಳಗಡೆಗೆ ಬಂದಿಲ್ಲ. ವಿಲ್ ಸಿ ದಿಟ್ ಏನು ಮಾಡ್ಬೋದು ಅಂತ, ಬಟ್ ದಟ್ ಈಸ್ ಕನ್ಸಿಡರ್ಡ್. ಎಸ್ ಸರ್. ಸರ್ ಇನ್ನೊಂದು ಹೇಳಿ ಸರ್. ಹಾಂ ಕರೆಕ್ಟ್ ಸರ್. ಒಂದು ರೈಟ್ ಸರ್, ಕರೆಕ್ಟ್ ಕರೆಕ್ಟ್ ಸರ್. ಅದು ಒಂದು ಈಗ ಸೆಕ್ರೆಟ್ರಿಯಾಗಿ ಹೇಳೋದಂತಲೇ ಈಗ ಇಷ್ಟು ದಿವಸ ಮೈಲ್ ಕಳಿಸೋದು ಮತ್ತೊಂದು ಎಲ್ಲದೂ ಈಗ ಒಂದು ನಾವು ಅಸೋಸಿಯೇಷನ್ ಮೆಂಬರ್ಸ್ ಆಗಿರ್ತೀವಿ. ಆವಾಗ ನಾನು ಯಾವುದೋ ಒಂದು ರಂಗನಾಥ್ gmail.com ಅಂತ ಕೊಟ್ಟಿರ್ತೀನಿ, ತುಂಬ ದಿವಸ ಆದಮೇಲೆ ತುಂಬೋಗ್ಬಿಡ್ತದೆ ಅಥವಾ ಇದೊಂದು ಆಗಿರೋದಿಲ್ಲ ಅಥವಾ ಚೇಂಜ್ ಮಾಡ್ಕೊಳ್ತೀನಿ, ಅದು ಅಪ್ಡೇಟ್ ಆಗಿರೋದಿಲ್ಲ. ಅದು ಒಂದು ಕಾರಣ ಇದೆ. ಕೆಲವು ಸಲ ವೆಬ್ಸೈಟ್ ಅಪ್ಡೇಟ್ ಮಾಡೋಕ್ಕೆ ನೋಡಿದ್ವಿ, ಆಗ್ತಾ ಇರಲಿಲ್ಲ. ವಿಲ್ ಡೆಫಿನೆಟ್ಲಿ ದಟ್ ಈಸ್ ಎ ಟು ಬಿ ಕನ್ಸಿಡರ್. ನಾವು ಡಿಸೈಡ್ ಮಾಡಿ ಅಟ್ಲೀಸ್ಟು ಒಂದು ಆಕ್ಷನ್ ತೊಗೊಳ್ತೀವಿ ಸರ್. ಸೊ ದಟ್ ವಾಟ್ ಎವರ್ ದ ಆಕ್ಟಿವಿಟೀಸ್ ಎಲ್ರಿಗೂ ಮೇಲ್ ಮಾಡ್ತಾ ಇದ್ವಿ ಸರ್. ಇವತ್ತು ಕೂಡ ನಾವು ಏನೋ ಸುನೀಲ್ ಆ್ಯಂಡ್ ಟೀಮ್ ಅವ್ರಿಗೆ ಕೇಳ್ಕೊಂಡಿದ್ದೀವಿ, ಒಂದು ಕೌಂಟ್ ಇಟ್ಟಿರಬೇಕು. ಸೊ ಅದ್ರ ಕಾನ್ಫರೆನ್ಸಿಗೆ ಬಂದಾಗ ಯಾರು ಅಪ್ಡೇಟ್ ಮಾಡಬೇಕು ಮತ್ತೊಂದು ಅಂತ ಹೇಳಿದ್ರೆ ಅದಕ್ಕೂ ಕೂಡ ಪ್ರೊವಿಷನ್ ಮಾಡಿ ಇಟ್ಟಿದ್ದೀವಿ. ನಮಗೆ ಕಳಿಸೋದಕ್ಕೆ ಕಮ್ಯುನಿಕೇಷನ್ ಇರೋದು 2-3, ಒಂದು ವಾಟ್ಸಪ್ಪು ಇಲ್ಲಾಂದರೆ ಮೇಲ್. ಸೊ ಹಾಗಾಗಿ ಅದನ್ನು ಕನ್ಸಿಡರ್ ಮಾಡ್ತಾಯಿದ್ವಿ ಸರ್, ಇನ್ನೂ ಕರೆಕ್ಷನ್ ಮಾಡ್ಕೊಳ್ಳೋದಕ್ಕೆ. ಎಸ್ ಸರ್. ಕೆಲವು ಮೆಂಬರ್ ಸಜೆಸ್ಟ್ ಮಾಡಿದ್ರು, ನೀವು ಏನು ಅವಾರ್ಡು ಅದೆಲ್ಲ ಏನು ಮಾಡ್ತೀರೋ 3 ತಿಂಗಳು ಮುಂಚೆನೇ ಅನೌನ್ಸ್ ಮಾಡಬೇಕು, ಸೊ ದಟ್ ಅದು ಗೊತ್ತಾಗಬೇಕು ಅಂತ. ಅದು ಮಾಡಿದ್ದೀವಿ. ಸೊ ಹಾಗಾಗಿ ಕ್ಯಾಚ್ ಅವಾರ್ಡ್ಸ್ ಏನಿದೆ 10-11 ಅವಾರ್ಡ್ಸ್ ಅಷ್ಟನ್ನು ಕೂಡ ಮುಂಚೆನೇ ಎಲ್ರಿಗೂ ಮುಂಚೆ ಕಾನ್ಫರೆನ್ಸ್ಗಿಂತ ಮುಂಚೆನೇ ಅನೌನ್ಸ್ ಮಾಡಿಸಿ ಇಂಥ ದಿವಸ ಬರ್ತದೆ ಅಂತ ಮಾಡಿಸಿದ್ವಿ. ಆಮೇಲೆ ಸೆಲೆಕ್ಟ್ ಆದವ್ರನ್ನ ಅದೇನು ಹೇಳಿದ್ರೆ ಗೊತ್ತಿಲ್ಲ, ಅವಾರ್ಡೀಸ್ ಶುಡ್ ಬಿ ಸೆಲೆಕ್ಟೆಡ್ 3 months ಬಿಫೋರ್ ದಿ ಕಾನ್ಫರೆನ್ಸ್. 3 months ಬಿಫೋರ್ ಪ್ರೋಸೆಸ್ಡ್ ಆಗಿದೆ. ಅನೌನ್ಸ್ ಮಾಡೋಕ್ಕೆ 3 months ಮುಂಚೆ ಮಾಡೋಕ್ಕಾಗಲ್ಲ. ಸೊ ಹಾಗಾಗಿ ರೈಟ್. ಆ್ಯಂಡ್ ನೆಕ್ಸ್ಟ್ ಕಾನ್ಫರೆನ್ಸ್ ಎಲ್ಲಿ ಮಾಡಬೇಕು ಅಂತ ದಯಾನಂದ್ ಅವರು ಕೇಳ್ಕೊಂಡಿದ್ದಕ್ಕೆ, ಸೊ ಹಾಗಾಗಿ ಅವರು ಕೋಲಾರಲ್ಲಿ ಮಾಡ್ತೀವಿ ಅಂತ ಒಪ್ಕೊಂಡಿದ್ರು. ಸೊ ಹಾಗಾಗಿ ಅವರಿಗೆಲ್ಲ ರೆಡಿ ಮಾಡ್ಕೊಂಡಿದ್ದೀವಿ. ಅದಾದಮೇಲೆ ಲಾಸ್ಟು ಕಾನ್ಫರೆನ್ಸಲ್ಲಿ ಡಾಕ್ಟರ್ ಅಜಯ್ ಕುಮಾರ್ ಅವರಿದ್ದರು. ಸೊ ಅವರೇ ಪ್ರೆಸಿಡೆಂಟು ಪ್ಲಸ್ ಆರ್ಗನೈಸಿಂಗ್ ಇದ್ದಿದ್ದರು. ಅವ್ರದ್ದು ಟೆನ್ಯೂರು ಲಾಸ್ಟ್ 23 ಇಂದ 26ವರೆಗೂ ಫೆಬ್ರವರಿ ಮಾರ್ಚ್ವರೆಗೂ ಮಾರ್ಚ್ ಟು ಮಾರ್ಚ್ ಫೈನಾನ್ಷಿಯಲ್ ಆಗಿರೋದ್ರಿಂದ ಮಾರ್ಚಿಗೆ ಮುಗಿದೋಯ್ತು. ಅಷ್ಟೊತ್ತಿಗೆ ಎಲೆಕ್ಷನ್ ಮಾಡಬೇಕು ಅಂತ ಡಾಕ್ಟರ್ ಗಿರೀಶ್ ಸಜೆಸ್ಟ್ ಮಾಡಿದ್ರು. ಸೊ ಹಾಗಾಗಿ ಮಾರ್ಚಿನಲ್ಲಿ ಮೇಡಮ್ ಡಾಕ್ಟರ್ ಲಲಿತಾ ರಾಮಯ್ಯ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಪ್ರೊಫೆಸರ್ ಇದ್ರು, ಅವ್ರನ್ನ ರಿಕ್ವೆಸ್ಟ್ ಮಾಡ್ಕೊಂಡಾಗ ಶಿ ವಾಸ್ ಎ ಎಲೆಕ್ಷನ್ ರಿಟರ್ನಿಂಗ್ ಆಫೀಸರ್ ಆಗಿದ್ದರು. ಸೊ ಹಾಗಾಗಿ ಶಿ ಇಸ್ ಕಂಡಕ್ಟೆಡ್ ಎಲೆಕ್ಷನ್ ಆ್ಯಂಡ್ ಈ ಬಾಡಿ ಕೂಡ ಬಂತು. ಸೊ ಹಾಗಾಗಿ ವಿತ್ ದ ಹೌಸ್ ಪರ್ಮಿಟ್ ಸೊ ದಟ್ ದ ಕ್ಯಾಚ್ ಬಾಡಿ ಅಂದರೆ ಎಕ್ಸಿಸ್ಟಿಂಗ್ ಗಿರೀಶ್ ಅವ್ರದ್ದು ಮತ್ತು ರವೀಂದ್ರ ಅವರು ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟು, ನಾನು ಜನರಲ್ ಸೆಕ್ರೆಟರಿ, ಆಮೇಲೆ ಮಂಜುನಾಥ್ ನೇಕಾರ್ ಮತ್ತು ನಮ್ಮ ಮಾಲ್ತೇಶ್ ಅವರು ಜಾಯಿಂಟ್ ಸೆಕ್ರೆಟರಿಸು ಟ್ರೆಜರರ್ ಆ್ಯಂಡ್ ಮತ್ತು 7 ಜನ ಮೆಂಬರ್ಸ್ ಸೆಲೆಕ್ಟ್ ಮಾಡಿದ್ದಾರೆ. ಸೊ ಅದನ್ನು ರ್ಯಾಟಿಫಿಕೇಷನ್ಗೆ ಬಾಡಿ ಅಬ್ರೂವ್ಸ್. ಸೊ ದಟ್ ವಿಲ್ ಕಂಟಿನ್ಯೂ ಫಾರ್ ನೆಕ್ಸ್ಟ್ 3 years 26 ಇಂದ 29ವರೆಗೂ. ಇಷ್ಟು ಲಾಸ್ಟ್ ಟೈಮಲ್ಲಿ ಯಾರಾದರೂ ಕೋರ್ದನಿ ಮತ್ತು ಸರ್ ಎಲೆಕ್ಷನ್ ಮಾಡಿದ್ದೀವಿ. ಸೊ ದಟ್ ರಿಸಲ್ಟು ಮೆಂಬರ್ಸ್ ಇಷ್ಟು ಆಗಿದ್ದಾರೆ.
ಎರಡಕ್ಕೆ ತಗೋಬೇಕಾದ್ರೆ ಒಂದು ಆ್ಯಕ್ಷನ್ ಟೇಕನ್ ರಿಪೋರ್ಟ್ಗೆ ಎನಿ ಕಮೆಂಟ್ಸ್ ಆನ್ ದ ಆ್ಯಕ್ಷನ್ ಟೇಕನ್ ರಿಪೋರ್ಟ್ ಲೆಟ್ಸ್ ಗೋ ಫಾರ್ ದಟ್.
ಸೊ ಅಷ್ಟು ಇಷ್ಟು ಲಾಸ್ಟ್ ಟೈಮ್ ಡಿಸ್ಕಷನ್ ಆಗಿದ್ದು. ಆಡಿಟು ಹೇಳಿ ಮತ್ತು ಎಲೆಕ್ಷನ್ ಮಾಡಿ ಅಂತ ಹೇಳಿದ್ರು, ಅಷ್ಟು ಕೂಡ ಆಗಿದೆ. ಸೊ ಐ ರಿಕ್ವೆಸ್ಟ್ ದ ಮೆಂಬರ್ಸ್.
ಎನಿ ಕಮೆಂಟ್ಸ್ ಆನ್ ದ ಆ್ಯಕ್ಷನ್ ಟೇಕನ್? ಓಕೆ,
ಥ್ಯಾಂಕ್ ಯು ಸರ್.
Okay. Okay. Thank you. Can someone propose and someone second? ಯಾರಾದರೂ ಹೆಸರು ಹೇಳಿ so that it can get into. ಡಾಕ್ಟರ್ ಕೊರೋದ್ಯಾನ ಮಠ್
ಪ್ರಪೋಸ್ ಮಾಡ್ತಾರೆ. ಫಸ್ಟ್ ಮಾಡಿದ್ದಾರೆ. ಸೆಕೆಂಡ್ ಬಾಲು.
ಸೆಕೆಂಡ್. ಓಕೆ, ಈಗ ರ್ಯಾಟಿಫೈಯಿಂಗ್ ದಿ ಎಲೆಕ್ಷನ್ ರಿಸಲ್ಟ್ಸ್ ಪ್ರಪೋಸಲ್. ಓಕೆ, ಬಾಲು ಸೆಕೆಂಡೆಡ್, ಮಾಸ್ತಿ. ಓಕೆ.
ಸೊ ಇಷ್ಟು ಲಾಸ್ಟ್ ಟೈಮು ವಾಟ್ ಆರ್ ದ ಆಕ್ಷನ್ ಟೇಕನ್ ಇನ್ ದ ಪ್ರೀವಿಯಸ್ ಜನರಲ್ ಬಾಡಿ ಮೀಟಿಂಗ್ ಅಂತ ಆಯಿತು. ಸೊ ಇದರಲ್ಲಿ ಏನಾದ್ರು ಹೌಸ್ ಈಸ್ ಓಪನ್ ನಾವು ಫಾರ್ ದಿ ಎನಿ ಡಿಸ್ಕಷನ್ ವಿತ್ ಪರ್ಮಿಷನ್ ಆಫ್ ಚೇರ್. ಎಸ್.
Okay, I think what was proposed last time, if I am not wrong, is it's not conference, planned division-wise activity, maybe division-wise quiz, and that division comes and does. IAP-noreಲ್ಲ ಮಾಡ್ತಾರಲ್ಲ, something like that. I believe what Dr. Arvind meant, and I think Dr. Girish and me are discussing this very long time. CATCH should in fact have division-wise representation, because district-wise ಮಾಡೋದು ಕಷ್ಟ. I don't know whether each college will be willing to do a district branch. It should be the goal. Unless we have district presence, nothing moves. So I think that is what I think I can understand from Dr. Arvind and comments or suggestion given in the last catch. Division-wise activities, munchene plan ಮಾಡಿ 1 year-ಗೆ, so that everybody is clear what workshops, what activities catch will do, and every division gets something to do, provided the college also should be willing. ಹೇಳಿದ ತಕ್ಷಣ ಡಿವಿಷನಲ್ ಕಾಲೇಜ್ನವ್ರು ಮಾಡಬೇಕು.
ಸೊ ಥ್ಯಾಂಕ್ ಯು ಬಾಲು ಸರ್. ಮೇ ಬಿ
ಒಂದು ನಿಮಿಷ, ನಾನು ಹೇಳಿದೊಂದು 2-3 ವಿಷಯಗಳು ಒಟ್ಟಿಗೆ ಸೇರಿಸ್ಬಿಟ್ಟು ನಾನು ಬದಲು ಹೇಳ್ತೀನಿ. ಫಸ್ಟ್ ಪಾಯಿಂಟು ಬಂದಿದ್ದು, ಲಾಸ್ಟ್ ಟೈಮು ಜನರಲ್ ಬಾಡಿಲಿ ಬಂದಾಗ ಐ ಹ್ಯಾಡ್ ಎನ್ಕ್ವೈರ್ಡ್ ಫ್ರಮ್ Zoho Corporation whether they'll be able to give us a package which could help us manage the accounts, manage our activities, plus also help us manage our members database. Tentatively yes andidru, then quote kottaga it went to almost about 9 lakhs. Then we had a lot of discussion. 9 lakhs ನೋಡಿ, ಕೋಟ್ ಕೊಟ್ಟಿದ್ದಾರೆ ಅಷ್ಟೇ. that is later. Let's not get into. Then they also suggested, if it's an NGO, if it is a registered body, then there are options wherein we can claim and then it can become almost nil or to the extent of 2 to 3 lakhs. One critical thing where it got stuck is they said it should get integrated as part of development of a website. Development of a website at least ನೀವು 2.5 ಲಕ್ಷ ಕೊಡಬೇಕು ಅಂತ ಹೇಳಿ ಡಿಸ್ಕಷನ್ ಅಲ್ಲಿಗೆ ನಿಲ್ತು. Even now every 15 days this person calls me up and then says ಮಾಡ್ತೀರಾ ಅಂತ. Having had some experience, I think website in that sense is not a priority for us to get it done in that sense, but what we want is a membership database, better management. We require something to do with conference management related. ಅದಕ್ಕೆಲ್ಲ ಕೇಳಿದ್ದಕ್ಕೆ as of now we haven't found decent software which we could use. Software iglide, but the problem with us is we are not used to that sort of working. Allik samasyak bandide. I'll just complete Balu. So adrinda, considering that, and then subsequently when I took over as president from 1st April, I had a discussion with the existing website vendor, Mr. Dr. Mrutyunjay Konenta. He's a BDS graduate, but is working with websites or supporting websites of Government of Karnataka, Rajiv Gandhi University, etc. He is doing it at a very dirt cheap level. I think first development was given as 18,000 and per year maintenance is given at 12,000, 16,000. He showed a lot of enthusiasm in the month of April. I told him that we want a new or a slight modification in the website. Kach membership, new membership form, Kach old members rejuvenation form antellanu. Last 2.5 ತಿಂಗಳಿಂದ ಹಿಂದೆ ಬಿದ್ದಿದ್ದೀನಿ. He gave me a draft of the entire form day before yesterday. I have circulated to a couple of people whom I know and they have filled it up. The form works well, but I know IT problem hegide anta. We should do that sort of a bit more of testing. Then this Kach membership, Dr. Korodhyanamat heldore, it will now be auto manageable. Neevu nimma email haki with your photo and other details. So it gets linked up to one common email ID so that any information to Kach will come as part of whatever email you have registered. If you want to re-register, that also is possible. One problem with all these emails is you can give any other email ID and then it may not. So it is also password related, so it will generate. So there is some checks and balance built, but I have received that only day before yesterday. It is working, but I didn't have the confidence to roll it out across. Tumba baididaitu, saying that we missed this opportunity of getting at least the 500 people who were here re-registered. ಹಲವಾರು ಕಾರಣಗಳು ಹೇಳಿದ್ರು, ಅವರ ವೈಫ್ ಹುಷಾರಿರಲಿಲ್ಲ, then he was out of country, everything. But one thing is very clear, I have seen a lot of these IT companies, we will go to pay them less and they will always take us for a ride or ride ಅಂತ ಹೇಳಲ್ಲ. It is also technology, it is also the cost of human resources. ಬಿಟ್ಟು ಹೋಗ್ತಿರ್ತಾರೆ, there is a huge turnover there. ಸಮಸ್ಯೆಗಳು ಅವ್ರ ಹತ್ರನೂ ಇದೆ, ಸಮಸ್ಯೆಗಳು ನಮ್ಮ ಹತ್ರನೂ ಇದೆ. ನಮ್ಮ ಸೆಕ್ರೆಟರಿಗಳೇನೆ ಅದಕ್ಕೆ 1 ಲಕ್ಷ ಬೇಕಾಗತ್ತೆ ಅಟ್ಲೀಸ್ಟ್ ಒನ್ ಟೈಮ್. We have sort of negotiated about 67,000 rupees for managing all these things one time, plus a recurrent expense of 30,000, which includes conference management. ನನ್ನ idea ಇದ್ದಿದ್ದು conference management ಏನು ಬರುತ್ತೆ, that the conference organizers anyhow they will have to pay for it. ಅಲ್ಲಿಂದ ಅರ್ಧ ಬರ್ಬೋದು, ಕಾಚಿಂದ ಅರ್ಧ ತಗೋಬೋದು ಅನ್ನೋ ಐಡಿಯಾ ಇತ್ತು. I think that should work out. ಬಟ್ ಸಾಹೇಬ್ರೇನೆ 1 ಲಕ್ಷ ಕೊಡಲ್ಲ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಗಲಾಟೆ ಮಾಡಿದ್ರು. But we have sort of convinced him. But the problem is the vendor is still not given us the invoice since last 1.5 months. ಹೀಗೆ ಆಟ ಆಡಿಸ್ತಾ ಇದ್ದಾರೆ. That's a real problem. Now changing the vendor will mean changing the whole thing again, which becomes a bit more troublesome. Second part of the problem is we have now got standardized 2 email IDs on behalf of Kach. That is contact@kach.org.in. Because if you look at it, Kach Journal 1984@gmail.com, Kachcon @gmail.com, ಹಲವಾರುಗಳು ರಂಗನಾಥ್ ಅವರು ಹಿಸ್ಟಾರಿಕಲಿ ಬಳಸ್ಕೊಂಡು ಹೋಗ್ತಿದ್ದಾರೆ. I just wanted him to avoid use everything with only these 2 email IDs. Anyone who wants to write to Kach should write as contact@kach.org.in. If we from Kach wants to write to us, it will be official@kach.org.in anta. So this is standardized. As of now, we have got that email IDs that has been energized, but not actually working. I think internally we should be modifying it so that Kach awards or otherwise will now come from this official email ID and will not go back into Gmail. It's not got all the features in the world, but it is functional. I think we should be able to use that part of it. The third point which Balu brought out, we thought as per the bylaws or as per the whatever we have been discussing, we should be getting in people from the regions also selected so that they can become part of the Kach EC. Oh, before I forget, I think Sudarshan sir is there. Let me also submit to him. Sir, last time I think in Mysore conference you said at least there should be a monthly meeting of the Kach EC. When periodic at helidri EC meeting anta. So one hantದ ತನಕ ಅದಾಯಿತು ಸರ್. ಆಮೇಲಿಂದ 2 ವರ್ಷ ಆಗಲಿಲ್ಲ. So after I took over from April, I think we have been having regular EC meetings. It will be on the first Thursday of the month. Every month Thursday, between first Thursday of the month between 6:30 to 7:30. Dr. Maltesh Shundi will be the coordinator for that. So if there is any issues related to Kach, please inform him or write to us at contact us at kach.org.in. He will also have access to it so that we will streamline that part of it. Now, we did not go into that regional wise because we thought we will have a election for only that particular regional representatives. I spoke to the auditor and the lawyer. They said, get it approved in the general body in terms of making a changes in the bylaw, submit it, and then you should be able to deal it through. So we'll take that as a very specific suggestion. Dr. Anantram is there. Yes, me and Anantram will be part of that bylaw modification. We will circulate it so that within this year itself, we will have a special election, get in regional representatives. We'll go with whatever Dr. Balu had suggested with respect to the TB program. There is already one existing regions. We could tally with that so that there is some functional way to go forward.
So what I mean to say is don't modify bylaws. Don't create again one more structure at division level. Okay, I don't think we need to create division level bylaws which is going to impact tomorrow. What it was suggested is Karnataka has 5 administrative divisions. Plan your 5 if I'm not wrong. It is 5 bank. Maybe then they removed the greater BBMP, we don't know. We have 5. If no, 5 divisions. No, it's okay. Let's not worry how many divisions Karnataka has. Don't change bylaws to make representation coming from the division. It is not required. The idea is sometimes there is clustering of activities in Bangalore, or sometimes it will happen in some place. Catch should facilitate activities in all division by identifying whoever we know or whoever we are in contact with. We have good representation in the government now. Davadi or Arun is there. There are so many people. There are so many trainings happening in those divisions by government itself. If we can request government to permit our PGs to attend that through Catch, that is enough. That's what I meant. Don't change bylaws and again let's not land in trouble.
Okay, point
point
noted. First, I'll thank you for including Kach logo into all your meetings. I think that's one appreciation which we should say. When several of us are hesitant, I think Dr. Balu makes it an effort and comes forward and incorporates it as part of Kach activity. Thank you very much for that. I'll just expand on that. Can you suggest zonal representatives for each of these divisions? So we could work along with that and then continue forward.
Ella zone or yaru illa. So it's good Catch.
Suggest madadre name, so we'll follow it up.
No, it can be biased. I don't know. So it's good to put it in the group.
Suggestion can be there, and then it can also change. We'll take that as a suggestion.
No, sir.
Okay, Bangalore division in the anyone?
If they volunteer, it is good. Otherwise, again, there will be one more chair, one more post.
Let's go one quick round. Bangalore
Anybody
division.
from Bangalore? That Ramaya junior staff is there.
Bangalore division.
Yeah, he's
Alla,
there.
apart from the EC members, let's look apart from the EC members who are already there.
Alla, you have EC members only 5 division. You only coordinate for time being.
See, these divisions for a change. Divisions are based on the population and other things, but here we are relatively. But here we are looking at the number of medical colleges. So so where more so then we have to look at how many medical colleges and divide into 4 or 5, and then look at the activities around that. That's what I mean. I think you were looking at whatever it is. But there are few here and there also. They also, if they are interested in that area also, there should be activities. What Dr. Balu is talking about actually.
ಸರ್ ಈಗ ನೀವು ಹಂಗೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ವೈಸ್ ಮಾಡ್ಕೊಂಡು ಹೋದರೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ದಿನ ಒಂದು ಹೊಸದಾಗ್ತಾ ಹೋಗುತ್ತೆ. ಆ್ಯಂಡ್ ವಿ ನೀಡ್ ಟು ಅಲೈನ್ ಕ್ಯಾಚ್ ವಿತ್ administrative division for 2 reasons. There is so many trainings which happen at divisional level. Like I was there in Mysore yesterday. DD is there for that division. So each division has DD, if I am not wrong, correct? So it's good we stick with what government has made administrative systems and align whoever is there to coordinate with that government system. Whenever there is some training, they will allow us. PGs hogvakaste, hogalla. But at least we should make an effort.
Point taken. I think colleagues are saying here that we'll not get into nominations now. I agree with that. Let's look at least by end of tomorrow if we can have some more names who could be part of it, so that they can immediately become part of the next Kachcon, and then we could plan for it.
So my suggestion is there is a catch group, WhatsApp group. Please post it today. Conference ellaru bandiralla.
Yeah, we'll do that. Dr.
Post it in
Maltesh.
the group. If nobody responds, then take a call on nomination.
Sure, we'll do that.
Yes. Now,
We'll do that.
I'll just add one more point. I think we need to come away from this website unless we are making it dynamic. What do I mean by dynamic? Now, how many of us look at any website? No, nobody looks at it nowadays, right? ನೀವು ಕ್ಯಾಚ್ ವೆಬ್ಸೈಟ್ ಡೆವಲಪ್ ಮಾಡ್ತೀರಾ ಅಂದರೆ ಅದ್ರಲ್ಲಿ ಏನಾದ್ರು ಲರ್ನಿಂಗ್ ಮಾಡ್ಯೂಲ್ ಮಾಡ್ತೀರಾ, ಸಮ್ ಸರ್ಟಿಫೈಡ್ ಕೋರ್ಸ್ ಮಾಡೋದಿದ್ರೆ ತಲೆ ಕೆಡಿಸ್ಕೊಳ್ಳಿ. Otherwise, I don't think we need to break too much head on the website.
Illa, we are not working on that website. The proposal was from Zoho that they will work on the website. Through that, make it available. We have rejected that proposal. We said we'll work with the current vendor itself. He has now energized 2 email IDs. We had asked for about 5. He said every email ID will cost us 1,800 rupees per year, just for maintenance. So we said we can't afford. One he is given free of cost, one he will give us gratis. So it comes with the package. So 2 email IDs is good enough for us. We are happy with that. Now,
why don't Catch can't explore app so that you can put all the learning materials or whatever you want? It is cheaper.
Okay. Good suggestion, but having understood how these apps work, I want someone to volunteer where we'll float that idea. Let's see how this could come out.
No, don't develop it, sir. Create a team which looks at possibility of an app, content ಏನಿರುತ್ತೆ ಅದರಲ್ಲಿ, ಅದರಿಂದ ಯೂಸ್ ಏನಾಗುತ್ತೆ. ಸುಮ್ಮನೆ ಮತ್ತೆ one more app should not be there in phone. That's what I'm saying. If we are making everything dynamic. ನಾನು last time catch group ಅಲ್ಲಿ ಹಾಕಿದ್ದೆ. There are so many seniors. Pai sir idare, Sudarshan sir idare. There are so many seniors. Have once in a month Zoom interaction. Let them talk their journey of public health. That is enough. No need for scientific sessions. Because many youngsters don't know. As new PGs, new faculty join, they need to know many people who have contributed to public health. Zoom is free.
We'll activate that part of it. I think there were a lot of discussion within our group itself, trying to look at what could be a series of programs. Dr. Anantram has got a proposal. I will request him to put that proposal to the GB in terms of, he has got 2 specific things which he would like to plan as part of this activities. One is popularize more activities, and then second is also he wants to propose a newsletter. Now let's listen to him first. Anantram, you'd like to do it now or a bit later? Okay, please come over. While he is getting ready, there was another effort made by the EC trying to contact all the heads of the departments. 60 colleges were there. Rangnath gave us the number, 10, 20 each. Dr. Seema I think she finished it fast. The others have been a bit slow. She has been able to contact all the 20, so we were trying to look at least through that, energize the and finalize the members who would be part of that, so that we can update it in a very realistic manner. Yes, Anantram.
Yes, thank you for this opportunity, sir. Firstly, I think newsletter is missing from what many organizations or many associations in Karnataka and across are doing. So being a part of Catch, we should have our newsletter. One, to unite the community medicine departments and to make others know what is happening across the state. Second, to for our own dissemination in terms of in faculty achievements and student achievements and publications and research collaborations. So these are the things that can be part of newsletter. I have a few things noted in terms of possible contents. It will start with the President's or EC desk, highlights of our activities, each department of all medical colleges, snapshots and updates, spotlight feature, maybe an opinion piece, and a research corner, academic corner, CMEs, public health perspectives and news for, related to the state, faculty student achievements, announcements. So these are some of the things that can be part of the newsletter. So I propose that we have a PDF version of it and quarterly editions of newsletter. And each medical college can have one representative who will collate maybe monthly or quarterly about what is happening in the department. And each department will have a fixed space for telling about their story to the newsletter. It can start with editor-in-chief, associate editors, and department nodal officers, and which can be rotating every 2 years. So this is one proposal regarding the newsletter.
We'll circulate this proposal in the group and then take final comments from all of them and then sort of energize. Any deadline you would like to keep?
By end of this?
1st October?
1st October for the first edition, sir.
First issue,
Yeah,
which we could bring out?
Yes.
Okay. First issue and first activity. Okay. If that is okay with all of you, we could take that as one specific thing which could count. Is that okay? Any comments? Okay. Regarding quickly to respond
I have
to
one submission, sir. Seymour ಮಾತಾಡ್ತಾ ಇದ್ರಾ? ಮಾತಾಡ್ಬಿಡ್ಲಿ. ರಶ್ಮಿ ಅವರು.
Madam, welcome. We will designate you as the social media coordinator. Please do help us out.
No, because the updates can be put up easily there.
I'm sure, 100% sure that we will be able, immediately in 10 seconds, I'll be able to open the Kach social media on Instagram, X, Facebook, all of them. But the wherewithal to update it is a behavior, it's a strategy.
Everyday work, yeah.
Now, if you are willing to contribute to that Kach, I will propose that you be nominated as a social media manager or coordinator for Kach. Is that, if that's okay with you, we will propose that. I will propose that.
We can do it, but there should be a way out, no? That we get information. Getting an information is important. Updating, I can do it, not an issue. But somebody has to, like if you get a newsletter or something, you're talking about those. Such ones, if immediately can get some photos of them, putting it up is not an issue, or updating it is not an issue. But informations we should get through.
Okay,
or any informations, like for example.
Let's work on this. Dr. Anantram has proposed something. We will work on that and then possibly link it up to the proposed
Yeah, it can
social
run
media.
parallelly, ma'am. I agree with you. All the updates can be both in social media and quarterly in newsletter also.
It is. Dr. Sudhashri and Dr. Seema are there in the EC.
She particularly said president or secretary, like in the heading positions, not as a representation.
ಅಲ್ಲ ಗೊತ್ತಾಗ್ಲಿಲ್ಲ ನೀವೇನು ಹೇಳ್ತಿದ್ರಿ. ಹಾಂ. Okay. Okay. If, alala, if, alala, alala, Dr. Alala, if anyone wants to sit in the president's chair, immediately I will vacate it and then would not be an issue. I will propose. Okay, point. Thank you, Dr. Ramakrishna. Point noted. Yes, Dr. Hemgiri.
So last GB meeting alli kuda this proposal was there. This proposal was there. So there should be a maximum number of lady the representation in the GC panel. Last time alli ittu, but yaru barlilla.
Okay, point noted. I would request Dr. Anantram to make note of this so that when you are looking at bylaws changing, this could be a very specific point which could be mentioned there.
You can't keep changing bylaws for every question asked in the AGM. It's an open election. You're allowed to nominate. If you're nominating, we can't help. Just because you change bylaw, how do you expect somebody will again send nomination?
The question is not that, Balu. Question is, there is one open thing. Plus also there is a possibility of you need to look at, if you are going to align with whatever the country is looking at, 1/3 of them should be members.
ಅದೇ ಅಲ್ಲಿ ಪಾಸ್ ಆಗಲಿ ಆಮೇಲೆ ಪಾಸ್ ಮಾಡೋಣ ಇನ್ನು ಅಲ್ಲೇ ಪಾಸ್ ಆಗಿಲ್ಲ ಇಲ್ಲಿ ಯಾಕೆ ತಲೆ ಕೆಡಿಸ್ಕೊಂತೀರಾ
Irli. Point taken. Understood the discussion. Let's move forward.
See,
move forward.
If you want, there is always open elections. Now, making 1/3, how are you expecting that nominations will come when we have kept it open? I don't think we need to change bylaws for these kind of
Let
things.
that point be included as part of a
No, I think
bylaw. Okay.
that's a good
Let it get
suggestion
reflected.
from Dr. Rashmi and others. But at the same time, as we say, it's a democratic. This one, it is even if 80% also want females also, they can always compete for that, contest for that. That should not be an issue.
No, question is not that. Spirit was Professor Sudarshan
Sudhashri
suggested two, and which also was
a
accepted.
lot of rich experience to this conference came from Dr. Sudha only.
I think it was an open invitation. I remember all the executive committee members reaching out to all the members to apply for the various posts. We could have applied for any post, so I don't think so there is anything. I think we have to come voluntarily, and next time I will apply for the secretary post. Thank you.
Okay.
No, I just have one submission.
There are two other points. My secretary is reminding that it's already.
Sir, last point from my side.
Okay.
Congrats for Catch for initiating the PG award. Dissertation PG thesis award. Let's keep one rolling shield for it. ನೀವು ಬರೀ ಸರ್ಟಿಫಿಕೇಟ್ ಕೊಡ್ತೀರಾ. Let's give very good rolling shield, just like we have in TB program. This year this PG gets, his name will be there, it goes to the next PG, next year.
Point noted.
Please note down, if nobody is giving, ನನ್ನ ಹೆಸರು ಹಾಕ್ಬಿಡ್ರಿ, ಬೇಕಾದ್ರೆ ಒಳ್ಳೆ ಕಪ್ ಮಾಡಿ ಕಳಿಸ್ತೇನೆ.
Okay, done. Thank you. Okay. Just to build on that, thank you for volunteering for the rolling cup. One decision that which EC made in the beginning itself is to have a multi-member awards committee, because for several years we had a one-man committee, one-person committee, and then we moved on to 3, 5, 7-member committee, and sometimes it was just one. So we've decided to make it mandatory that it will be a 5-member committee, and then it will stay for 3 years till the term of the EC, so that people know what is the decision, and also the chairperson of that committee will have clarity on and will be more comfortable in terms of looking at judging the awards or the individuals, and then coming out with the award list for Kachcon. So as per the EC's decision, I would also request the GB to ratify that. Dr. Ravindra Reddy has been requested to be the chairperson of the committee. What we have thought is one of the vice presidents will always be the chairperson of the Kach Awards Committee, and 2 members from the EC and 2 members from outside the EC will be members of this committee, and thereby invite, and the secretary of Kach will be the member secretary of that committee. I'll request Dr. Ravindra to share what the challenges he faced and
Yeah,
the
thank you.
criteria which he adopted.
Thank you. So we had, I think this time in the morning it was announced during the inauguration, I was offered as a chairperson and member secretary, Dr. Ranganath, and we had Dr. Renuka as one of the expert, and Dr. Ramesh Masti and Maltesh only. So 5 people are there in the committee right now. So when we were taking, of course, we took inputs from all the people, including the criteria which are already existing for the awards. But sometimes we had the tie. That was when we had a challenge, especially for the Young Scientist Award and dissertation. These are the 2 we had. Then we were deciding what to do. So then we adopted additional involvement in the catch activities, including participation in the conferences and CMEs. So that was adopted now. That I propose, if there is a tie, as a tiebreaker, we can include this as an additional criteria for this one. That was one challenge. So this I propose to the August body to ratify that. In this case, in that case, this can be one of the additional criteria as a tiebreaker. That is one thing. Second is the dissertation which was introduced this time. Though there are so many PGs across the state today, so many PGs, but many are not members. So one of the criteria is they should be catch members also. So they were not eligible to submit. So that was, so not many actually came. So from next year, we want to see a lot of dissertation to be submitted for the award. I think as he said, the rolling shield also will have a real meaning, right? And it is there. So these are the 2 things.
Why you want PG to be member to get an award? My simple question.
You know,
PG to
Why
be member
you want
to
PG
get the
to be a
dissertation
member
award.
for catch to deserve an award? That is bias. Judge give award based on the thesis, not because he is catch member, IAPS and namik sambandha illa. This is wrong. Faculty award, yes, you make all those rules. Why you want to make
See,
for
these are actually, please note, dissertations are submitted after they completed the PG post-graduation, and their faculty actually are working somewhere else. So they have not become members then also.
Okay.
That means
no, that is okay.
That should be
last time it was rejected because he was not member.
Let me. I think I stand for correction. I stand to be corrected. We have drawn out protocols. I think the point is any MD community medicine dissertation in Karnataka is accepted. The only criteria between Kach member and otherwise is that cash award which comes in. I think that's the idu. I'm liable to, let me check what the protocol, whatever is that. So it is not. Your point is there. Any community medicine, MD community medicine or public health thesis which comes out from an institution which is from Karnataka is eligible for it. So
no, I agree with this
and
point
it's not the
also.
individual,
No,
but that
as I said, see, dissertation is submitted mostly after the examination. So once they are already passed, still they are not catch members.
Sir, ಇವಾಗ ಕರ್ನಾಟಕದಲ್ಲಿ 50% PGs ಔಟ್ ಆಫ್ ಸ್ಟೇಟ್ನವರು ಅವ್ರು ಯಾರು ಮೆಂಬರ್ ಆಗಲ್ಲ 115 ಜನ ತಮಿಳುನಾಡಿನವರು ಇದ್ದಾರೆ
ಅಲ್ಲ I don't know. Anyhow, this is for discussion.
ಅಲ್ಲ ನೀವು ಡಿಸ್ಕಸ್ ಮಾಡಿ ಸರ್ ಐ ಆಮ್ ನಾಟ್ ಎಗೇನೆಸ್ಟ್ ಆರ್ ಫಾರ್ ಬಿಕಾಸ್ 50% ಇಲ್ಲೇ ದೇವರಾಜ ಸ್ಥಳರಿ ಎಲ್ಲರೂ ಕೇರಳದಲ್ಲಿರೋದು
Illa, Balu, let's flag this issue. I'm 100% sure by memory that any MD dissertation or a public health dissertation is eligible for the award. But the cash prize given is only to a Kach member and it's not given to a non-Kach member. It's just that criteria so that they encourage them to become a Kach member.
ತೆಗೆದ್ಬಿಡಿ ಚೀಪ್ ಅನ್ಸುತ್ತೆ ಕೊಡೋದೇ 2000 ಅದರಲ್ಲೂ ಕ್ಯಾಚ್ ಮೆಂಬರು ನಾನ್ ಮೆಂಬರ್ ಯಾಕೆ
Early point. We will take the sentiments of the general body and then we will discuss internally. Okay.
ಲಾಸ್ಟ್
Early bidi.
ಲಾಸ್ಟ್ ಒನ್ ಭಾಳ ವರ್ಷದಿಂದ ಹೇಳ್ತಾ ಇದ್ದಾನೆ ದಯವಿಟ್ಟು ಕ್ಯಾಚಿಂದ ಏನು ಸರ್ಟಿಫಿಕೇಟ್ ಕೊಡ್ತೀರ ಅದಕ್ಕೆ ಒಂದು ಚಂದ ಫ್ರೇಮ್ ಹಾಕ್ಸ್ಕೊಡಿ ಇವತ್ತು ನೋಡಿದೆ ಪೇಪರ್ ಥರ ಕೊಟ್ವಿ oration given as certificate. All certificates, ಯಾವುದೋ ಸ್ಕೂಲ್ ಮಕ್ಕಳಿಗೂ ಈಗ ಅಂಥದ್ದು ಕೊಡಲ್ಲ, ಫ್ರೇಮ್ ಆಗಿ ಕೊಡ್ತಾರೆ. It is not good on our part. How
Okay.
much does a frame cost? 500, 600 rupees. Why can't we get
It's not a
frame
question
done?
of cost. The question was, we had this discussion at the EC. We take your point, we'll go back to the EC because EC finally decided that we will not go with framing of it for several reasons. But we will take this point and then discuss again and then revert back on
ಮತ್ತೇನು
that.
ಡಿಸ್ಕಸ್ ಮಾಡೋದು ಸರ್? ಇಲ್ಲ ಮಾಡ್ತೀವೇನ್ರಿ? ಇಲ್ಲ ಇಲ್ಲ
ಆಯ್ತು.
ಅದೇನು ಈಸಿ?
Hello, please permit the EC to independently deliberate on that. But your point is well taken. I agree with that. We'll take that.
ಫ್ರೇಮ್ ಹಾಕೋಕೆ ಈಸಿಗೆ ಹೋಗ್ಬೇಕಂದ್ರೆ ಇದು ಬಾಡಿನೇ ಅಲ್ಲ.
ಏನು?
ಒಂದು ಸರ್ಟಿಫಿಕೇಟಿಗೆ ಫ್ರೇಮ್ ಹಾಕಕ್ಕೆ ಎಕ್ಸಿಕ್ಯೂಟಿವ್ ಕಮಿಟಿ ಡಿಸ್ಕಸ್ ಮಾಡ್ಬೇಕಂದ್ರೆ ಅದು ಅಲ್ಲೇ ಬಾಡಿನೇ ಅಲ್ಲ ಇದು.
ಅಲ್ಲ,
ಒಂದು ಸರ್ಟಿಫಿಕೇಟ್
ಅಲ್ಲ.
ಫ್ರೇಮ್ ಹಾಕಕ್ಕೆ ನೀವು
See, let's be democratic. The process what we have followed is what we will do ಅನ್ನೋದನ್ನ, there was a discussion which happened, and in that discussion it was decided that it not to be done. Now it's always fair enough that we go back and then discuss. We will take the sentiments, that is what I said. I'm not saying no. There was some reason why the EC said no.
Now
We will go
explain,
back and revert and
let
then
EC explain why you didn't, what was the reason you didn't make certificate frame?
ಇಲ್ಲ.
Tell me now. I'm a AGM member, you tell me.
I would suggest that we have taken the sentiments of the house.
ಸೆಂಟಿಮೆಂಟ್ ಬೇಡ, ಈಗ ನಂಗೆ EC ಯಾಕೆ
ಇಲ್ಲ.
ರಿಜೆಕ್ಟ್ ಮಾಡ್ತು ಕೊಡಿ.
It is not a financial constraint, it is more a functional, because what was told is, there are 2 or 3 issues which come up whenever such awards are there. One is the size of the award. If you look at it, the size of the award is now made into an A4 size uniformly across all of them. The memento what is given is also sort of uniform, the same size across all of them. And third is, if you start framing, now what is the type of frame which you need to look at? And then, as I said, instead of that, if we want to keep it in our files, it is easier we keep it, whether we want to put it on our wall or otherwise. So finally the EC said, okay, it is easy for them, rather than put it up, frame it up and then give it to them. They can put it into their files and
ಎರಡು
that would
ಕೊಡಿ,
be
ಒಂದು
easy.
ಫ್ರೇಮ್ ಹಾಕಿ ಕೊಡಿ,
See,
ಒಂದು ಹಂಗೆ ಫ್ರೇಮ್ ಕೊಡಿ, 10 ರೂಪಾಯಿ
we
certificate,
can
ಯಾಕೆ
always
ತಲೆ
differ on
ಕೆಡಿಸ್ಕೊಂತೀರಾ?
this, whether it's right or wrong. It was one decision taken. Now the general body is saying another decision. We will value it and we will take it up, act on that in the coming things.
Sir, simple thing, whoever is hosting next conference, ask them, send them the certificate, let them make it ready,
Point
keep
taken.
everything ready.
Point
Momentance also, they can only make
It is not an issue of-
ಮಾಡಿರ ದೇವರಾಜರ್ಸ್ನ ಇನ್ನೊಂದು 5 ಕೊಡಕ್ಕೆ ಬರಲ್ಲ.
It is not an issue of
ಮಾಡಿ.
cost. We have taken that on record. We will act on that. Okay.
ಇವೆಲ್ಲ ಸಣ್ಣ ಸಣ್ಣ
Point noted, sir. Point noted. Point noted. Let's move forward on that. Okay. Now, Dr. Ravindra, anything else you would like to say? Regarding the Kach Awards Committee, request the GB to ratify this 5-member awards committee. And then this will be the awards committee henceforth. The chairperson of the awards committee will review the criteria what is there and circulate it. Now it will be made widely available so that this confusion what was there would now be at least absolved. Yes. Yes, sir. It has been a practice since Dr. Naglod. BMC ಇಲ್ಲ, ಅದಕ್ಕೆ ಮುಂಚೆ ಬಾಗಲಕೋಟೆ ನಮ್ಮ ಸರ್ ಹೆಸರು ಅಲ್ಲಲ್ಲ ಹಾಂ ಗತ್ತರ್ಗಿ ಸರ್ volunteered and then said 100 rupees per head per delegate, registered delegate will be given to the Kach general pool. It is being practiced more or less. Dr. Dayanand is not here. He had some difficult. Oh, idare. ಎಲ್ಲರೂ ವಾಲಂಟಿಯರ್ ಆಗಿ ಕೊಡ್ತಾರೆ ಅನ್ನೋದು ಭರವಸೆ ಇರಲಿಲ್ಲ. ದಯಾನಂದ್, it is there. It is Yeah, it is there.
Cash becomes a regular active body with good amount of money so that they can increase and improve it.
Yes, sir. Noted. This is one of the points which is raised to the host committee. I think Dr. Sunil would agree on that. 100 rupees per head per registered delegate will be given to Kach Finances to manage all their activities. It's a regular one. It's a regular one. It's regular. There is no second thing about it. Okay.
Girish?
Madam.
Yeah. I think one of the other thing I wanted to suggest was in the Kachcon today, I think we had more delegates outside than inside. I think, do we need 1.5 days or 2 days of conference if the PGs are not interested? Because I feel that most of the sessions were directed to the PGs and for their learning. It was not for all of us. So even thinking about the effort of accommodation and everything, do you want to just do a one-day conference with only PG presentations? Because tomorrow I'm sure 8 to 10 they'll all be in the halls. So if that is the purpose or that is the intention of the PGs, then we should not be all wasting resources of the college, our time, and also getting all the speakers. It was very difficult for me to get government speakers and escort them and bring them here and make them sit the whole day. But then if we don't have, I think it is not good on our part.
Yeah, there is a larger discussion which needs to happen on this.
Second this or any
Yes,
other
Doctor.
ideas? One row, first row occupied.
Yeah, in fact, Professor Shivram, before he left, he made it a very specific point. I'm not able to be in the general body. Please rethink. It's reached a plateau. You need to think how else or what is the different ways you could have a conference.
Yes.
Warm suggestions are welcome. I think, yes, Dr. Gautam.
So nowadays, demography is very important. And the community health.
A bit louder.
The community health landscape is also changing. I would like to suggest the EC to look at pros and cons of having associate membership for Catch. There are many people, associate membership for Catch. There are many people who don't have an MD or DNB in community medicine or community health, but are still practicing community health in different degrees as well. So if you can have an associate membership, one, it would increase the numbers, it would increase the revenues. It might solve the problem of people not being on the chairs as well.
Yeah. Associate membership is there, but it's not sort of activated till now. We'll actively pursue that part of it. Yeah, quick.
Sir, from KMC.
Thank you. I think we'll take that, but just to reflect on that, just give you one. I'll just move on to the next agenda because we need to be looking at who will be hosting the Kach 2027.
Before that, I just have one point.
Okay.
Yes, from KMC point of view, Vice President, he was frequently telling me that if any conferences or CME are conducted from any organization or Catch, any institute, for that institution, whoever is the organizing chairman, if you write a letter when you are sending for the CME credit points, they are going to offer you 25 to 50,000 funds. So that can be done. So in 2024, I think JSS, they received 50,000 for conduct of the conference. So that can be utilized, sir. So that is actually, it's not done.
Okay, thanks for the information. Catch 2027 ಹೇಳ್ತೀರಾ? ಇಲ್ಲ ಬಂದ್ಬಿಡ್ಲಿ ಅದಕ್ಕೆ. ಇದು ಕವರ್ ಮಾಡ್ಕೊಂಬಿಡಿ.
So next to catch conference ಮಾಡಲಿಕ್ಕೆ I request members ಯಾರಾದರೂ ಇಂಟ್ರೆಸ್ಟ್ ಇದೆ somebody. Dr. Ramesh, please come forward. thank you, Dr. Ramesh from the KMC Mangalore. For this, we will discuss with higher ups and to proceed further.
Yeah,
So the next
I think
catch on 27.
I just wanted this point to be discussed because I think there is a lot of suggestions. Dr. Ramesh, you have a tough job ahead. So when you're planning the scientific sessions, please do keep in mind some of the points raised in the GB now, plus also particularly the point which Dr. Mahesh raised. You have access to about 25 to 50,000 from KMC if you are applying in advance. So that also could be a good source. Okay, I think we go into the next agenda, the treasury. Huh? One.
On September 28th, World Rabies Day, KIMS Department of Community Medicine will be hosting a half-a-day CME involving in Bangalore, different government hospitals, medical colleges. So it will be half-a-day program on September 28th. It will be on Monday. But we will put catch. It will be under catch and APCR because.
Thank you, Dr. Ashwath and Dr. Ramesh Masti sir for. Definitely, so catch will be the first to support Kempegowda Institute of Medical Science, Department of Community Medicine. We'll be happy to be associated with this Department of Community Medicine KIMS. PG, adu agilla.
Okay, I have got another agenda more important for today. That is report by the treasurer. Request treasurer to.
Dr. Girish.
Good evening, everyone. Coming to the accounts of the catch. So we have a SB account in the SBI branch at the in the Bangalore Tipu Sultan Road, and coming to the account details from 1st April 2025 to 31st March 2026. So the opening balance was 1,89,401. So membership fee which we got this year, actually we had good number of new members, 35 new members, 35,000 we had. So and SBI interest we got 5,566. So that is around 2,29,967. Coming to the expenses. So coming to expenses in this year, so we have the awards, prize money and all. For that we had around 16,000 as the expenses. Then the auditor charges and renewal of the association charges, 20,000. And also we have the certificates, printing and all for the prizes, everything. We had 3,900. Total 40,000 as the expenses for the year. So and we for the actually in the Gulbarga conference. So they had actually requested the association account to be used, as we have also PAN for the association. So totally they use for the few fundings they use the association account. 3,40,000 they got credited to our account, and that was withdrawn actually. Deposited was 3,49,000 was deposited. So even 9,000 extra, that is for the association they have paid. So that is there. And also coming to the association, opening balance of 1,89,401, closing balance of 1,96,455. So that is the closing balance. And also, as we've been knowing, with the catch we have the FD accounts. 4 FD accounts we have, that's been auto-renewed. So as of now, we have 8,85,517 as this FD account balance is going on. So that is there. So this is the total account details, and also the auditing is done. So we have submitted all the receipts and everything, and the audited copy has been shared in the group. So that details also everyone can see in this current group. It has been posted. Thank you. And this is the details, and I request to propose and second. Thank you. Thank you.
Thank you. One other objection, they don't have any objection with respect to ours, but there might be some objection which we might get because if you keep too much money in the FD, there is liable that it may considered as income and then government can charge us tax on that. So we are trying to see how that clause can be avoided or how we will be able to show some activities. That is also an imperative when you raise the issue of refresher course. I think this also puts us back into spending money, not just keeping it in the account. That is one. A second issue which has been raised is probably our objection has come in terms of our general bodies are not held sometime during March or April. So we have tried to find out, and the solution seems to be there is a possibility that we can have a online general body. So we plan to have one online general body either in the month of, regularly in the month of April, and one more general body this time, possibly sometime during December. We will announce once the bylaws get modified, we will circulate it and then have an online general body. So request for your support and cooperation in that regard, so that this can become streamlined. Whatever general body we have during the conference will be a special general body or one other general body, so that we will be as per records. This is one of the comments made by the auditor, and this would help us in compliance to that. If there is no other point, I take this opportunity to thank Devaraja's Medical College Department of Community Medicine for all their there has been, yes, I'm timing it now. Okay. Thanks to SDUMC, our secretary has got a special mention.
Thanks to Dr. Arun Kumar because his contribution is great in the conference for the posting this medical officer from the by request Madkonda Commissioner ge, plus also he helped us in raising some funds on the issues. Thanks to Dr. Arun.
The system recognizes, sir. The DHO remembered that he had posted some people here and people attended the conference. So in that sense, 15 were posted for this. Thank you for that support, sir. So if there are okay, please do help us out with respect to adding more people into the Kach members group. Several of them have missed out. So in case if you know anyone whose number is not there, please write to Dr. Maltesh or write to us at contact us at kach.org.in. We will include them as part of being members of the WhatsApp group. At least let there be one strong group which we can look at. With these words, on behalf of the entire EC, would like to thank you for making it a grand success with all our with all its limitations and the challenges what we faced. Thank you.
Yeah, one.
On behalf of Executive Committee, I thank everyone who attended the General Body meeting and provided your valuable inputs. I also thank President Sir, Dr. Girish Sir, Secretary Sir, Dr. Rangnath Sir, and also Chairperson of Award Committee, Dr. Ravindra Sir, Treasurer, Dr. Girish Sir, Joint Secretary, Dr. Manjunath Sir, and all the Executive Committee members of Catch for being present and helping out us. Thank you, one and all. And last but not the least, I thank SDUMC for hosting the conference and providing an opportunity to conduct the General Body meeting. Thank you, one and all.